But it's good. Good for health.
Nossa, coitado.
So how we can proceed? So initially, I present my case.
Yeah, the first step, you present your case. After that, Victor Arantes and Fernando Fluchat discussion with you. And finally, you comment about the
Boa tarde, professor Celso Ardenque. Boa tarde, professor Lix. Hoje daremos o início no terceiro Seminário Internacional de Endoscopia e Gastroenterologia do Itaigara Memorial Gastro. Esse é um evento que já vem acontecendo há alguns anos. E nesse terceiro seminário, nós chamamos o Dr. Celso Ardengue, o Lix, para fazer as contribuições e para organizar esse evento com a gente. O memorial tem uma longa carreira na parte acadêmica. E isso vem se manifestando através do grande número de pessoas ligadas ao curso. Então, é sempre um prazer em receber vocês, mas agora eu passo a palavra para o doutor Celso Carlos Ardenque para fazer a sua abertura e, posteriormente, para o professor Lix Alfredo Reis de Oliveira. Dr. Celso Ardengue, ele é do Departamento de Cirurgia e Anatomia da Universidade de São Paulo, Brasil, e o Dr. Lix é professor da PUC Campinas, Brasil. Professor Celso, a palavra é com você.
Ok, muito obrigado. Eu quero dar as boas-vindas a todos aqueles que estão participando, a todos os inscritos, a todos os professores. Eu quero também agradecer ao honroso convite que foi feito pelo Dr. Rodrigo Felipe em participar desse congresso, né, desse simpósio, que é realmente um evento de sucesso já no Brasil. Esperamos ter colaborado um pouco em relação à via biliar e pancreática, da qual nós tivemos o cuidado de escolher pessoas de vultuoso nome internacional em relação aos procedimentos tanto na via biliar quanto pancreática. E eu quero dar as boas-vindas a todos, espero que vocês aproveitem esse evento, porque realmente é um evento que foi feito com grande carinho. Muito obrigado a todos pela presença.
Bom, primeiro, boa
do ouro AMS como patrocinador para
Para cuidar da sua saúde, é sempre bom ter em quem confiar. Por isso, faça como eu. Use os medicamentos EMS, a maior farmacêutica do Brasil. Há quase 60 anos, a EMS está ao lado de cientistas, investindo para desenvolver os mais inovadores medicamentos que cuidam da sua saúde. Então, na hora de escolher, peça medicamentos EMS. Sua saúde merece.
Melhores resultados vêm das melhores escolhas. E Probid é a melhor escolha entre os probióticos. Probid tem a exclusiva tecnologia Biosuporte, que garante a resistência das cepas ao ácido gástrico, entregando-as vivas ao intestino. É o primeiro probiótico com alegação funcional aprovada para auxiliar na redução de complicações gastrointestinais, dor abdominal, náusea e vômito. Além de ser o único com atuação no eixo cérebro-intestino, comprovada por estudos clínicos, auxiliando no alívio a sintomas gastrointestinais relacionados ao estresse. Equilíbrio e bem-estar para uma vida mais saudável. Probid, único com atuação no eixo cérebro-intestino.
A Labormed atua no mercado nacional de videoendoscopia digestiva e cirúrgica desde 1988. Trabalhamos com atendimento de qualidade na comercialização, distribuição e pós-venda de nossos produtos. Contamos com uma rede moderna e bem equipada de assistências técnicas espalhadas por todo o Brasil. Além disso, somos a única empresa certificada para atuar no reparo e assistência de equipamentos Fujifilm. Labormed. Entre em contato conosco.
o professor Noria vai fazer um update desse caso. Então, eu passo a palavra agora a Noria e o Edo, em seguida, para discussão e debate, doutor Vitor Arantes e o professor Eduardo Guimarães Moura. Por favor, Noria, fique à vontade para a sua apresentação.
Thank you for invitation.
Muito obrigado pelo convite.
And I want to share my slides.
Eu quero compartilhar. Está tendo um retorno tremendo aqui para mim. Eu estou ouvindo a minha própria voz. Eu tenho que falar em português. Os participantes selecionam o idioma inglês, se quiserem ouvir em inglês, nas suas telas. O pessoal da técnica tem como resolver esse retorno aqui? Eu não posso estar ouvindo a minha voz. Obrigado. Obrigado.
Excuse me. Can you hear my?
Não, melhorou.
Can you see my
Vocês estão
slide?
me ouvindo? Estão vendo meus slides?
Yes, professor.
Now.
Go ahead.
Okay. Thank you for invitation. So I would like to show
Gostaria
present
de
one case of
apresentar um caso.
plasm. So as you know, treatment of strategy
Como vocês sabem, as estratégias de tratamento do SCC esofágico
based on the depth of tumor invasion.
dependerá da
If the
profundidade
lesion is confined
da
to the
invasão tumoral.
mucosa, endoscopy dissection
Só
can
está
be
voltando.
indicated. But if it invades some mucosa,
Se ele invadir
other treatments such
a
as
mucosa,
esophagectomy or 100% of specificity for some mucosal invasive cancer. And another indicator is the size of a vascular area. So according to size of a vascular area, we can estimate the size, estimate the depth of tumor invasion of squamous cell carcinoma. So according to shape of irregular vessel and the size of a vascular area, we can predict the depth of tumor invasion. So I present my case. He is age in 60s, and he has a GERD symptom, and he received EGD and revealed a superficial lesion in the esophagus. He's a drinker and a face flusher. He did not smoke, but like this. And he had some mental bit illness. But anyway, we scope this patient. So we found two lesions. One is upper esophagus and superficial lesion, like this. Maybe you can see irregular vessels as a brownish area, like this. And maybe you can see a avascular area, small avascular area. And the lower esophagus, there is this type of lesion. So it has somewhat like an obvious depression in the left side of the wall, like this. And with magnification, so with magnification, we see some non-loop vessel like this. It freezed. So, how can I? Okay, wait a moment.
Probleminha aqui com o professor, mas ele vai botar para gravar, ele vai botar para rodar o vídeo. Um minutinho.
Freezed.
Algum problema na conexão, pessoal?
So,
O professor Noria está tentando destravar o vídeo dele, mas acho que ele consegue. Um minutinho só.
wait a moment.
Vitor, essa imagem aí, a princípio, antes, a professora Noria botar o vídeo dele para correr. Vocês acharam, o que vocês estão achando dessa imagem que ele mostrou no esôfago, na magnificação, com esses vasos tortuosos? A gente pode ir debatendo enquanto o professor Noria tenta ligar o vídeo dele. Eduardo, Vitor.
Sorry, I reboot my computer.
Voltou, Eduardo. Voltou.
I will access again. Sorry.
Ok, boa tarde a todos. Enquanto o professor Noria está reposicionando sua apresentação, gostaria de agradecer o convite ao Dr. Rodrigo, Dr. Celso, Dr. Lix, cumprimentar também o professor Eduardo Moura, um prazer estar com ele nessa sessão. E é um prazer participar desse seminário. O professor começou a mostrar a classificação de magnificação e cronomoscopia virtual para estimar a profundidade de invasão das neoplasias escamosas do esôfago. E é uma classificação hoje muito utilizada, tanto quanto a ecoendoscopia, para as neoplasias superficiais. Eu diria até que mais utilizada do que a ecoendoscopia. Podemos colocar no nosso meio, né, Eduardo? A dificuldade que temos é de ter acesso a esses endoscópios de magnificação. Não são tão disponíveis, mas eu já coloco aqui uma questão para discutir a magnificação versus no estadiamento da neoplasia superficial de esôfago.
Bom, boa tarde a todos. Mais uma vez é um prazer estar participando de um evento organizado a comissão que organizou esse evento. Agradecer ao Rodrigo, agradecer ao Li, pela lembrança.
Magnifying
termos de
NBI
CT1B.
shows
A
T1A
imagem
muscularis mucosae or sallow submucosa, but EUS
na
suggested
região da
it
submucosa
is
também
submucosal and no lymph node metastasis.
não houve
So,
metástase linfonodal aqui.
how we have to go treatment?
Então temos que
So,
buscar algum tipo de
I
tratamento.
think this is clinical T1B N0M0
Esse CT1B
carcinoma.
N0 M0
So I think there is a two option, surgery
tinha duas opções,
or
ou cirurgia
non-surgery.
ou não
Patient
cirurgia.
is 60 years old,
Paciente
so
com
surgically
60
fit
anos,
patient.
até
But he
bem,
refused
em forma,
to surgical treatment
caso não
because he
se
has
optou
some
pelo tratamento
mental
cirúrgico,
illness, so he is
porque ele tinha alguns problemas
worrying
mentais
about the surgical treatment.
e
So
ficaria
he
muito
accepted
inquieto com o tratamento cirúrgico,
chemoradiation therapy.
mas aceitou a quimio-radioterapia.
So we offer and after
Fazer
that
uma ressecção
chemoradiotherapy.
endoscópica.
So initial endoscopy resection show
A
that
ressecção
the
depois da
cancer invade
quimio-radioterapia mostrou
muscularis mucosae, but did not invade some mucosa.
que o tumor invadiu parte, mas não toda essa mucosa, parte dela, mas não toda.
So T1A muscularis mucosae and
Então,
N0M0.
AMM com N0 M0.
We can follow up without additional treatment, but the
Fizemos o
patient
follow-up
was a bit worrying about
sem tratamento adicional, mas o
recurrence
paciente
or metastasis. So
estava
we
preocupado com a
perform
possibilidade de
additional
metástase.
chemoradiotherapy as a planned
Por isso,
treatment.
e o paciente foi encaminhado para quimio-radioterapia conforme planejado.
Incidence of lymph node metastasis
A incidência de
is
metástase
report
linfonodal
of pathological muscularis mucosae squamous cell carcinoma is reported to be from 0 to 16%.
a metástase linfonodal em casos ressecados cirurgicamente
And the metastasis
na faixa de
recurrence
0 a
rate
16%. E o índice de
after
recidiva
observation
da metástase em casos
reported to be
observacionais
0 to 6%.
varia de 0 a 6%.
So not really zero. So
Não é zero exatamente.
because the patient is 60 years old and
Como o paciente tem 60 anos
physically fit, so
e
we
está
offer the
fisicamente bem,
chemoradiotherapy.
nós então propusemos a quimio-radioterapia.
So what is the clinical relevance of
Qual é a relevância
EUS
clínica
for
de
staging
usar a
of
EUS para
esophageal
estadiamento
squamous cell carcinoma?
do T1, do
Recent
carcinoma?
one study showed that initially, if we make diagnosis
Inicialmente, se nós
of depth
fizermos
of
o
invasion by
diagnóstico
conventional endoscopy or
invasão
magnifying endoscopy,
utilizando
and
a
after that,
endoscopia
if we perform EUS, about
utilizando o
6%
EUS também,
of the
6%
lesion can be overdiagnosed.
das lesões
So
podem
it
ser
causes
sobrediagnosticadas.
overtreatment.
Ou seja, o que nos leva a
So in this
sobretratamento.
study, they conclude that
Neste estudo,
this
eles
does not
concluíram
support routine use of EUS for staging
que
of
não há apoio
T1
para o uso de
esophageal
EUS de
squamous cell
rotina
carcinoma.
após uma endoscopia convencional
So what is the meaning of
para esses carcinomas escamocelulares.
additional endoscopy resection before
A ressecção de
chemoradiotherapy?
endoscopia foi feita antes da quimio-radioterapia.
If we compare the outcome between
Se nós
surgery
compararmos
and
os
chemoradiotherapy
desfechos
for
entre
stage 1
cirurgia e
esophageal
quimioterapia
carcinoma,
para o carcinoma
overall survival
escamocelular como
is
esse,
almost
a
similar.
sobrevida geral é
However,
praticamente 0,7%.
sometimes
Então,
chemoradiotherapy causes local recurrence.
a quimio-radioterapia provocou recidiva local.
Therefore, non-recurrence, recurrence-free survival
A
is
sobrevida
worse
livre
in
de recidiva.
chemoradiotherapy. However, if we combine endoscopic resection before chemoradiotherapy, we can avoid such local recurrence.
Esse processo, antes da quimio-radioterapia, nós evitamos esse processo.
And also, we can reduce the
Nós podemos também
amount
reduzir
of radiation
a quantidade de
compared
radiação
to definite chemoradiotherapy. If we already remove primary lesion by endoscopic
Se você tiver já removido a lesão primária antes da quimiorradioterapia.
And another good thing of additional endoscopic resection before chemoradiotherapy is if we look T1B, but sometimes endoscopic resection found the lesion confined
na ressecção encontra-se uma lesão confinada na região da mucosa.
So in such case, we can avoid additional unnecessary chemoradiotherapy in such case. So recently, such combination of endoscopic resection plus chemoradiotherapy for stage 1 esophageal cancer is reported. This is a prospective cohort study. So according to their data, among 176 patients, about 40% of the patients could avoid chemoradiotherapy because endoscopic resection showed lesion is confined to the mucosa.
O tumor estava confinado na mucosa.
And the combination of endoscopic resection plus chemoradiotherapy showed the very good, excellent outcome of 90% of 3 years overall
survival. Uma
survival.
proporção de sobrevida da ordem de 90,7% em 3 anos.
So that is my case presentation.
Bom, este é o caso que eu tinha a apresentar.
If you have any comment.
Dr. Uedo.
Okay, so good morning, Professor Uedo.
Bom dia, Professor
And good afternoon to Dr. Eduardo Moura. Thank you very much for joining you on this session. Uedo Sensei, this was a very interesting presentation about the management of early esophageal cancer. And I must say that I agree 100% with you. And I would like to highlight key messages that you brought. First, when you have the magnification endoscopy and the virtual endoscopy for superficial lesion, I think these, and combined with the Lugol stain afterwards, I think it's enough for the majority of cases for the staging. I also almost don't use EUS routinely in my unit anymore. And basically, the case you presented about the lymph node in the celiac, in the mediastinum, I can tell you that all cases that I did perform EUS, they had lymph nodes, because those patients, majority of them, they are smokers. And they are smokers and heavy drinkers. And so we will always find those lymph nodes. So I don't pay too much attention on those lymph nodes. And that's the main issue that I don't use almost in the majority of cases EUS anymore. I rely more on the magnifying endoscopy and the visual inspection of the lesion as you have shown. So this would be my first comment. The second comment is that I totally agree that if you have a lesion that seems to be resectable endoscopically, that may even be a T1A or even a T1B with some submucosal invasion, if you remove the lesion totally, you have a much more reliable information to make a final decision. If you are going to submit patient for another procedure like surgery, like esophageal surgery, or just chemoradiation, or as you have shown, in 40 to 50% of cases, you end up realizing that the endoscopic treatment was curative, and there is no need for any additional treatment. So this would be the second key message that I would like to highlight from your presentation. So anytime you have a resectable lesion, And you have a team that is prepared to do this by endoscopic submucosal dissection. This is important. There is no space anymore for piecemeal resection or endoscopic mucosal resection in the esophagus. It would be only applicable for very tiny lesions, under 5 or 10 millimeters, very difficult case. So if you're talking about squamous cell cancer, you're talking about ESD. And then I would like to ask a question for you about the latest guideline from Japan and regarding the circumferential lesions. So the lesions that occupy 360 of the circumference. Previously, we were still accepting that indication, but now the Japanese guideline is being more restrict. So if the lesion is over 5 centimeters in size, there is no indication more for ESD, according to the latest guideline. And even if the lesion is very superficial, only case under 5 centimeters would be acceptable. So I'd like to ask you in Osaka, how you manage the circumferential lesion, and also if there is any role of chemoradiation before endoscopic resection, aiming to reduce the tumor, and then afterwards, maybe a local endoscopic resection of a smaller lesion, if this combination could be also applicable, and if you have any experience at Osaka. Thank you very much, Sensei.
Or specific for this case? What do you prefer?
So, still, we found that for delineation, margin delineation, lesion delineation, still chromoendoscopy provide a very clear margin. So, for depth of tumor invasion, we usually rely on magnifying NBI or NBI, but for margin delineation, we always perform chromendoscopy. So it means before the treatment, during the screening or detection, usually only NBI, but before the treatment decision, we always perform chromendoscopy.
Dr. Victor, have more questions?
Yes, sure. I have one more question for Dr. Uedo. Have you been using traction method in the esophagus routinely or in certain situations? How often have you applied the traction method in the esophagus? And which kind of method do you use to apply traction in the esophagus, please?
In our hospital, usually we use just a clip and line. So we tie the suture line to the clip, end clip, and then apply it. You maybe 30–40%. So it depends on the skill of the endoscopist. Our junior, maybe almost 100% they used. And actually, multi-center randomized control trial show that in esophagus, clip and line traction method significantly reduce the procedure time. So those who are learning or those who are practicing ESD procedure, I think it is very useful method.
And one more question, Cecil. Oh, sorry.
Yes.
Go ahead, Eduardo,
No,
please.
go ahead, Victor. Go ahead.
Yeah, just one more question, Sensei. For the semicircumferential resection, over 75% of the circumference, what is the protocol in Osaka Institute for the Postoperative Management, please?
So in our hospital, usually, if it is not the whole circumferential, we usually initially provide, administer local injection, thorium syndrome. And if it is almost semi-circumferential, maybe sometimes we provide, administer additional systemic steroid, prednisolone, from 30 milligram to tapering for 4 weeks or 6 weeks. But basically, we use local injection steroids.
Dr. Uedo?
Yes.
About the overdiagnosis and underdiagnosis. When you analyze the lesion and you suspect the superficial invasion for submucosa, you prefer resection for the lesion for analyzing the lesion, or if involved the submucosa tumor, you prefer to treat radiotherapy before, then decide about the technique you treat the patient.
Could you say it again?
About the overdiagnosis and underdiagnosis. Sometimes you have the patient, it's an invasion for submucosal invasion, but the superficial. When you have this diagnosis, because you are not, the diagnosis is not adequate, over or underdiagnosis. You submit the patient a resection for ESD, or you use the ultrasound endoscopy or other methods for analyze the lesion.
So, as I presented in my presentation, so recent study, prospective cohort study, shows that if we perform EUS, 6% of overdiagnosis can happen. So basically, additional EUS clinically, it is not so beneficial. So it can reduce underdiagnosis, but it also significantly increase overdiagnosis. So basically, if we basically we rely on conventional endoscopy
Nós
finding plus
utilizamos a
magnifying
endoscopia
NBI finding,
convencional.
and then if it is
Depois,
we decided it is
se
indication of
decidirmos
endoscopic
que a
resection,
indicação
we directly
de
perform
uma
endoscopic
ressecção,
resection, ESD or
então nós
EMR.
fazemos essa ressecção com endoscopia.
Sensei,
Eduardo,
if we have
Eduardo.
time, I'd like to make another question.
Gostaria de fazer uma outra pergunta,
We see that
Sensei.
the B2
Nós
classification of the
vemos
Japanese
que a
Esophageal
classificação
Society,
B2
the
da
accuracy is not
sociedade
so good.
japonesa,
Around
Yes.
50,
a acurácia não é muito
60%.
boa.
So, how do you
50,
envision we could
60%.
improve the
Como nós
accuracy of this
poderíamos
classification?
melhorar a eficácia dessa
Recently,
classificação?
some
Recentemente,
Japanese investigator
alguns investigadores japoneses
determine some limit of
determinaram
the
alguns
area
limites
width of B2 vessel. If it is smaller than 7
se for
millimeter,
menos do que 7
it
milímetros,
is still confined to the mucosa. But if it is
está confinado
larger
à
than
mucosa.
7
Mas
millimeter
se for maior
area,
do que 7
it is high
milímetros de área,
possibility of deep
há uma alta
invasion.
possibilidade de uma
So,
invasão profunda.
Recently, some kind of
Recentemente,
sub-analysis
temos
is performed, but still
analisado
not yet
esse
determined
desempenho,
very
mas
well.
ainda não é conclusivo.
Eduardo, may I ask one question
Posso
for
fazer
Professor
uma
Norio,
pergunta?
Eduardo?
Yes.
Go ahead, Celso.
Yes, Professor Norio Edo,
Professor
good morning. Thank you for your participation in our
Norio, muito
symposium
obrigada pela
and
sua
congrats for your
participação
good
no nosso
presentation.
simpósio
But I would like
e por a
to
excelente
do
apresentação.
one
Eu gostaria
question
de
and
fazer uma
the management
pergunta
of this case. In a case of
sobre
esophageal
conduta nesse
carcinoma,
caso.
with
No
a suspected
carcinoma
lymph node
esofágico
identified by CT, in
linfonodo
which the
de,
FDG is negative
onde o
in the
SG
PET
é
CT,
negativo,
would
quando
you,
testado,
at some moment,
o senhor,
do you
em algum
indicate, for
momento,
example, the AUS
iria
and
indicar
fine needle
o
aspiration or fine
EUS
needle biopsy
ou
in this
aspiração,
suspected lymph node, or never you use this technique?
ou você nunca utiliza essa técnica?
In our hospital, we seldom
Nosso
perform
hospital,
FNA for suspicious
nós
lymph node. I
raramente
don't know the real
fazemos isso.
accuracy. We are more
Eu não
rely on
conheço a acurácia.
rather contrast enhancement CT or sometimes additional PET CT scan.
Algumas vezes
And
também fazemos o PET-CT.
actually, in this patient, still
Nesses
PET CT was
pacientes,
negative, but
o
still
PET-CT é negativo.
there's some suspicious lymph nodes. So that is
Mas
also
se temos
reason
alguns
why we
linfonodos
offer
suspeitos,
additional
é por isso que nós
chemoradiotherapy, even it is
oferecemos a
confined to the muscularis
radioterapia
mucosa.
se
And the patient
estiver
was very young.
confinado num paciente muito jovem.
So that is a more tailor-made decision.
Okay, but in this
Essa é
case,
uma
what's
decisão feita caso a caso.
but in this case, for example, in this case that
Mas
you
nesse
presented,
caso,
what is the percentage of the indication of the chemoradiotherapy
radioterapia,
in the concern of the PET-CT?
essa preocupação que
So
pode surgir através do CT
basically, in this situation,
nessa situação,
chemoradiation therapy can be
a
performed for
quimiorradiação pode ser feita
clinical T1B
para
N0M0
T1B
as an adjuvant therapy.
M0M0.
So, and also it can be indicated
Pode
for
também ser
N1,
indicado
sometimes N1 is cancer as well.
N1.
So I thought this is a marginal case,
Esse é
but
um
I
caso
thought
marginal,
chemoradiotherapy
mas
must be effective,
quimiorradioterapia
and especially
pode ser
patient really
eficaz,
diffuse surgical resection.
especialmente se
So I
nós
think
tivermos caso
chemoradiotherapy is a
difuso.
very good indication in this case.
Então, quimiorradioterapia seria uma boa indicação nesse caso.
Thank you very much.
Regarding this topic, I think it's very
Em relação a
interesting
esse
because
tópico, eu acho que é muito interessante.
we usually don't recommend
Nós não recomendamos normalmente
chemoradiotherapy for M3 invasion without lymphovascular invasion, and especially if it's a R0 resection. I think this is a very
se for
special
ressecção
case.
R0.
Do you agree that in the majority of cases we
Você
could
concorda que na maior parte dos casos
not indicate the
não devemos
chemoradiotherapy
indicar
when
a
you have only M3
quimiorradioterapia
invasion, no
quando
lymphovascular
você
invasion,
tem
and
N3,
R0 resection?
nenhuma linfovascular, nenhuma invasão
I think
linfovascular?
still there is no answer.
acho que
And
não há
actually,
nenhuma
Japanese
resposta.
guidelines
Estudos
also
japoneses nas nossas diretrizes
stated that it
também
cannot be
falaram isso.
determined.
E não
Recommendation
pode ser
cannot be determined.
determinada essa
And as I
recomendação.
show the data
Eu
for
mostrei os dados
surgical case,
para os
pathological
casos cirúrgicos.
muscularis mucosae case has a 0 to
com
16%
0
of
a
metastasis rate,
16%
according to
de taxa
report.
de metástase
Of
de
course,
acordo
it
com
is
esse relatório.
retrospective, maybe some
É
bias.
claro que
And
é um
also,
estudo retrospectivo, talvez haja algum
additional
viés.
observe pathological muscularis mucosae and observed case about
Também em alguns
5%
casos,
of recurrence
5%
can be
de
developed
recorrência
according
pode
to report,
acontecer, de
0 to
acordo com esse
5%.
relatório.
So, pathological muscularis mucosae, not 0%. So, according to patient
Então, a mucosa
preference and
patológica não é 0% de
condition,
acordo com esse
physical
trabalho.
status, or some discussion, I think
Há
still
discussões,
some, indication, space of indication for such case.
indicações
Okay.
nesse caso.
Dr. Wedo,
Yes.
Dr. Wedo,
now I like to hear about you
Gostaria de
review the
ouvir
matter today. You have 10
sobre
minutes,
os
please.
métodos revisados. O senhor tem 10 minutos?
Maybe I think I can.
Não.
Eduardo Moura, alguma questão?
Any question?
Não mais nenhuma. Agora a gente está esperando ele fazer a revisão.
We're waiting for him to review as it is in the program,
Para a gente respeitar o horário.
so that we can respect the time.
Já passamos 2 minutos.
We are 2 minutes over the time.
So actually, I
Ele vai fazer uma
did
revisão do
not
caso.
prepare, but I want to
Eu não preparei,
repeat
mas
my presented data. So,
aqui os meus dados.
pathological muscularis mucosae,
patológica,
even vascular invasion
Mesmo com a
was
invasão
negative.
vascular
Still
negativa,
some certain percentage of
aí existe algum
metastasis
percentual
can be seen.
de
And
metástase que pode
also,
ser vista.
if we observe small
observarmos
number, but still
números pequenos,
recurrence can be happen.
mas ainda
So,
a taxa de
still
recorrência
for
metastática.
usually esophageal cancer patient, it is very old. So in
Normalmente
such
são pacientes
old
bastante
patient,
velhos.
maybe observation without treatment can be an
Então, talvez
option.
seja necessário
But
uma observação
very
apenas sem
young, very fit
tratamento.
patient, maybe additional treatment can be
Talvez para
also
aqueles
another
muito
option.
afetados possa haver uma indicação de tratamento.
And also, as I mentioned, this is also data. So additional
dados,
EUS decrease
EUS adicional
under diagnosis like this.
para aqueles que
But
decrescem o número
basically,
de
it increase
subdiagnosticados.
overdiagnosis.
Paciente
Total
também aumenta o
66.6%. But
6,6%
according to some small
de
lesion
acordo
or
com
lesion with
lesões
elevated
pequenas
component or
ou com
EUS
componentes
diagnosis was
elevados
low confident,
ou
or more than
diagnóstico com baixa
10% of
confiança, mais do que
overdiagnosis
10%
can be
desses
happen.
superdiagnósticos nesse caso.
And this is also the same. So endoscopy dissection before chemoradiation therapy can reduce local recurrence. And also, we can avoid additional over treatment for intramucosal cancer for this patient and provide overall good survival.
E temos uma boa sobrevida como um todo.
I hope this kind of information
Que esse tipo de
can be shared
informação
in
possa ser
Japanese and
compartilhada
Brazilian patients.
entre nossos colegas e pacientes brasileiros.
Okay, Sensei, there is a final question, and we really appreciate your presentation and your
agradecemos muito pela
expertise.
sua apresentação,
But the final
seu
question is,
conhecimento, mas
we
a
don't
pergunta
have
final
many
seria:
magnify endoscopy, especially from NBI in Brazil and Latin America? Do you think we can rely on mere focus to do this classification with NBI? This question comes from Professor Lix Oliveira, who is one of the organizers of this meeting.
Esse diagnóstico através desse método?
Probably for esophagus, maybe there is no data, but recently we have used near focus NBI and then evaluated the diagnostic accuracy in gastric lesion, early gastric cancer. So we found that it shows about 70% of sensitivity and 85% of specificity, which is better than white light conventional NBI, and not as good as optical zoom, but still it has it improve white light diagnosis. So I think still it is practically it can be used in a clinical practice. I think.
Situação clínica.
And especially recently, Olympus launched new system, X1 system. So it is compatible to 100 series and 200 series. So maybe it universally we can share the scope, endoscope, all over the world. So we can benefit all endoscopists in the world can be benefited.
Todos os endoscopistas podem ser beneficiados.
Dr. Uedo, one of the key points of endoscopic treatment of early esophageal carcinoma is the superficial invasion of the submucosa up to 200 microns. In your opinion, is it safe not to operate a young patient with superficial submucosa invasion?
Uma invasão superficial da submucosa?
As I mentioned, muscularis mucosae, even muscularis mucosae have around 5 to 10% of possibility of metastasis. And superficial submucosa has more. Usually, according according to data, it's a bit different, but usually 10 to 15%. So, especially for young patients, surgically fit or patients who can receive chemoradiotherapy, I don't recommend any no treatment, no additional treatment after endoscopic resection. Japanese guideline also recommend additional treatment for all submucosal carcinoma, including superficial carcinoma.
Mesmo até para os carcinomas superficiais.
Dr. Victor, your final comment, please.
Seu comentário final, Dr.
Victor. Actually, I just wanted to express our gratitude. We learned a lot in this session from Professor Uedo and his great expertise from this center. They publish a lot. They participate in the major trials in Japan about early esophageal, early gastric, early colorectal neoplasia. So it's always a great pleasure to participate with you in this session. And I'd like to express also the gratitude for the invitation of my person to this session, Professor. Thank you very much.
De pessoalmente estar presente nessa sessão.
Dr. Uedo, thank you. Unfortunately, our
muito obrigada.
And once again, we'd like to thank you all the participation, as well as the organizing committee.
A participação de todos e da comissão organizadora. Muito obrigado, Dr. Uedo.
Tem pequeno intervalo agora. O senhor segue. O senhor continua.
Have a small break, and you continue after the break, I believe.
Bom, boa noite a todos. Meu nome é Eduardo Moraes. Eu sou um oncologista clínico do Nobre Grupo Oncoclínicas e dando sequência a esse seminário, terceiro seminário.
In order to continue this third international seminar of Itaigara Memorial, we will continue with Professor Noria Uedo. He will deliver a presentation of a case for the treatment of stomach therapeutical diagnosis. And before anything, I would like to introduce the moderator, Dr. Assadu Jorge, who is a former chairman of the Society of Digestive Surgery from Uruguay, and our debaters, Dr. Nelson Miyajima, who is a physician of the Service of Gastrointestinal Endoscopy of the Clinical Hospital of the School of Medicine of the University of São Paulo, and Professor Luiz Masuo Maruta. He's the head of the endoscopy unit of the University of São Paulo Hospital. Now, let me invite Dr. Ueda. Dr. Uedo, again, are you ready for the next case presentation, Dr. Ueda? Dr. Uedo. We will do the same sequence. Dr. Uedo will deliver the presentation. We will be debating this case, and then he will make a review. Professor Uedo, you have the floor. Handle this.
Hello.
Hello.
Can you hear me?
Vocês me escutam? Yes, sir.
Professor, pode dar início a...
Professor, you may start your presentation.
Okay. Can you see my slide now?
Estão vendo meus slides?
Yes.
Okay. So I want to explain about the indication of endoscopy resection of early gastric cancer.
Da ressecção endoscópica.
So it is indicated to clinical T1A M0 cancer, which fulfilling indication criteria.
Os critérios de indicação.
And the method of endoscopy resection, lesion smaller than 1 centimeter, EMR can be applied, but a lesion larger than 1 centimeter, ESD is indicated. So at first, I want to clarify the difference between indication and the curability. To perform EMR or ESD, or not to perform EMR or ESD, indication is determined by endoscopic findings. And after that, specimen is histologically assessed, and then if it is fulfilled curative criteria, it is followed up without surgery. But if it does not fulfill histological criteria, patient is sent to the surgery. So before the treatment, indication is determined endoscopy findings. And after the treatment, curability is determined.
A curabilidade é determinada pelos achados histológicos.
And before the treatment, indication is determined according to histological type and the extent, lesion size, and the depth of tumor invasion,
tamanho, profundidade do tumor, a presença ou não de escaras ou úlcera.
And after that, histological finding is assessed. So I want to show one case. A patient is 70 years old and no remarkable symptoms. And he has H. pylori infection and no abnormal physical finding.
Câncer de mama sem achados anormais.
So this is a endoscopic finding. So patient has a extensive atrophy in the lesser curvature of corpus and extensive intestinal metaplasia in the antra.
Metaplasia intestinal extensa, é que se vê aqui.
So I want to avoid video.
É para corrigir isso e não fazer ajuste.
Anyway, so
tipo
please
macroscópio, por exemplo.
see
Tipo histológico, tamanho.
endoscopy finding.
Esses
What
são os
is
achados endoscópicos,
macroscopic
né?
type? And what
Qual é o
is
tipo
histological
macroscópico?
type, size,
Qual é o tipo histológico,
invasion
qual o
depth,
tamanho,
or
profundidade da
ulcerative
invasão
finding
e
to
achados
determine
ulcerativos?
endoscopy treatment indication.
Isso determina o tratamento.
So can you find some lesion?
Será que você pode encontrar uma lesão?
So here, so
Aqui, por
slightly pale flat lesion is seen.
Nós vemos lesões
Like
planas,
this.
como estas.
And with NBI, it is delineated like
No
this.
NBI, nós temos esse delineamento das lesões.
With magnification of this
Com
margin,
ampliação ou magnificação, vemos as
we can
margens,
clearly see the
vemos claramente
demarcation line and the irregular
as
vessels.
linhas demarcatórias.
And the chromoendoscopy does not work, did not work
Chromoendoscopia,
very well
nós
because
não
lesion
conseguimos
is
ver muito
totally flat.
porque as lesões são totalmente planas.
So we make diagnosis. This
Então, fazemos o
is
diagnóstico,
type 2C,
tipo
and
2C,
biopsy showed
e a
undifferentiated
biópsia
type,
mostrou
1
tipo
centimeter,
indiferenciado,
and
1
clinically
centímetro,
intramucosal, and no ulcer
clinicamente
finding.
intramucoso, sem ulceração,
So, according to
ou
recent
cicatriz. Então, de
Japanese
acordo
guideline,
com essa
even
guideline
undifferentiated
japonês,
type, lesion
o
smaller than
tipo
2 centimeter,
indiferenciado, ou seja, lesões
intramucosal,
menores que 2
no
centímetros,
ulcer finding, it is absolute indication of endoscopic
sem
resection.
escaras ou úlceras.
So we perform endoscopy
Com isso, nós realizamos
submucosal dissection.
as indicações. Daí fazemos a ressecção da mucosa.
So this is specimen,
Aqui temos o espécime
and we cut every 2 millimeter,
a cada 2 milímetros.
and this is a specimen.
E aqui está o espécime novamente.
So surface is
A
covered
superfície
with non-neoplastic epithelium,
está coberta de epitélio não
and
neoplásico.
signet ring cell carcinoma is
Carcinoma
diffusely exist in the lamina
mostrado aí
propria.
na extensão da lâmina própria.
So histological finding fulfilled curative
Os
criteria.
achados histológicos são cumpridos.
So resection was regarded as curative.
Então, a ressecação foi considerada como um procedimento curativo.
So when we compare the histological finding and
Quando comparamos
NBI
os
finding,
achados histológicos e achados do NBI,
surrounding mucosa has this type
a
of
mucosa
gland, duct.
ao redor
So we
tem
can
essa
see
forma de
some
dutos glandulares,
structure, duct structure.
uma estrutura
However,
ductal.
inside of
No
the
entanto,
lesion,
dentro
this
da
kind
lesão,
of gland was
esses tipos de
disappeared
glândulas
by the cancer involvement.
desapareceram em função do envolvimento do câncer.
Inside the lesion, this
Dentro da
kind
lesão,
of duct is
esse
disappeared,
tipo de
and
duto
only
desaparece.
vessel cancer vessel is seen.
Somente as células cancerígenas é que ficam visíveis.
So anyway, this is regarded as curative resection.
Ou seja, o tipo de ressecção considerada curativa.
So next, I want to show another
Em
case.
seguida, eu queria mostrar para vocês um outro caso.
A patient received eradication therapy before.
O paciente passou por uma terapia pós erradicação do tumor.
And this is another lesion.
Essa é outra lesão.
How about this?
E esta.
And this is retroflex view. And this is NBI finding.
Esse aqui é o achado NBI.
And inside of the lesion, surface
lesão,
is covered with some
a
epithelium,
superfície está coberta de epitélio,
similar to surrounding mucosa.
também em torno da mucosa
But in
que está ao
between
redor.
this type of mucosa
Mas
epithelium,
entre esses tipos de epitélios da mucosa,
there's some irregular vessels
existem vasos irregulares.
like this. And the chromoendoscopy, again, does not work very well.
Ela não
Because the
funcionou muito
lesion
bem
is
aqui,
covered with
uma vez que a lesão
non-neoplastic epithelium.
não apresenta a presença do epitélio neoplásico.
So lesion, this is 3 centimeter size.
Isso aqui, esse tamanho é de 3 centímetros.
So lesion was larger than 2
A
centimeter.
lesão era maior que 2
And,
centímetros.
With retroflex view, somewhat little bit elevation and the size suspect submucosal invasion.
Suspeita-se a presença de invasão da submucosa também.
So we made diagnosis this as a
Fizemos
clinically
diagnóstico
T1B.
De um câncer clínico T1B.
So we performed the surgery.
Realizamos a cirurgia.
And this is a lesion.
E aí está a lesão.
So surface, it is covered with non-neoplastic epithelium.
Com epitélio não neoplásico.
And the cancer is in the mucosa.
O câncer está presente na mucosa.
But it also invade some
Mas
mucosa.
ele também invade parte da mucosa.
And then reach to muscularis propria.
Vai para a região mais profunda.
So lesion is diagnosed as a pathological
É uma
T2.
lesão considerada patologicamente como T2, PT2.
So we have to find such kind of lesion, such small lesion.
Esse tipo de lesão, lesões pequenas.
To perform endoscopy treatment for undifferentiated type Arigaceae cancer.
Para cânceres gástricos do tipo não diferenciado ou indiferenciado.
So recently, a long-term outcome after endoscopy resection for undifferentiated type Arigaceae cancer is reported.
A remoção do tipo de câncer indiferenciado.
In this study, they enroll 260
Eles recrutaram 259, 260 aproximadamente.
And then followed up
pacientes.
For 5 years.
Fizeram seguimento durante 5 anos.
So they achieved unblocked resection rate of 99%.
Fizeram ressecção unblock.
And the curative resection was achieved in 70% of the patients.
Em 71% dos pacientes.
So one non-curative resection patient developed distant metastasis even after surgery. And one patient received gastric resection for metachronous gastric cancer after endoscopy treatment. But anyway, this study shows very good overall 5 years overall survival. So I want to add some information. Difference between subepithelial and submucosal extension. Usually before endoscopy resection, we perform mapping biopsy from the surrounding mucosa. Because sometimes undifferentiated type cancer extend underneath the epithelium. So for example, looks like this. The junior doctor put the marking. However, it looks like too small, so I put additional marking. So as a result, lesion extend or near or outside the marking like this. So subepithelial extension of the intramucosal region of undifferentiated type cancer should be diagnosed by mapping biopsy. So subepithelial extension is different from submucosal invasion. This advanced cancer we could not make diagnosis by biopsy. So we perform EMR. So we found that cancer cell exists underneath the submucosa. So this could not be, this cannot be make diagnosis by biopsy, because cancer cell is underneath the muscularis mucosae. But a subepithelial extension can be make diagnosis by biopsy, because cancer cell exists above muscularis mucosae. I think that's all.
Thank you. Thank you very much, Dr. Uedo. It's a pleasure to again about the Americas. And a pleasure to listen to your beautiful talk. So we have some time for the debate. We have the session. Sorry, here. Well, we have Nelson Miyashima, that is Doctor of Gastrointestinal Endoscopy Service at Hospital das Clínicas in São Paulo, and Luis Masuso Maruta, Head of Endoscopy Unit at University Hospital USP, Brazil. So welcome everyone to this session and to the debate. Nelson, we have some other colleague joining us in the debate now. I am aware.
Hi, Dr. Uedo.
Hi.
First, I'd like to congratulate for a great presentation. I'd like to thank the Itaigara Memorial Commission. It's a great pleasure to be here, Professor. Thank you for your participation, and it's a great session with our professor, Professor Luis Maruta. First,
Maruta. We can't hear you. No podemos escuchar.
Okay, Professor Uedo. In the first case, has very extensive atrophy and the intestinal metaplasia. Would be more expected if they differentiate the adenocarcinoma? It's what's your explanation? The detection, endoscopy detection, maybe it's very difficult. Do you have some point to detect such lesions?
em relação às áreas localizadas.
Please, Dr. Luiz Maruta.
Luiz Maruta.
Thank you, Nelson.
Perguntas? Sim.
I'd like to ask Dr. Uedo,
Dr. Uedo, eu queria lhe perguntar.
what is your opinion about
Qual a sua opinião
incomplete intestinal metaplasia?
Sobre a metaplasia intestinal incompleta.
And how to recognize on
Como
endoscopy
reconhecer
the incomplete
endoscopicamente
intestinal metaplasia?
uma metaplasia
Yes, very good
intestinal
question.
incompleta? Boa
So
pergunta.
many pathological studies show
Muitos estudos
that
patológicos
more high risk for gastric cancer
mostram
for incomplete
risco mais
type
alto de
intestinal
câncer
metaplasia.
gástrico
So previously,
comparado com as metaplasias incompletas.
it is very difficult to distinguish from complete or incomplete by endoscopy finding. But
Se
recently
é
we
completa ou
found
incompleta por
that
achados endoscópicos.
very whitish intestinal metaplasia is more likely to be
No caso
incomplete
de uma
type.
metaplasia, é mais provável que o tipo seja incompleto.
Magnify NBI, it is called white opaque
Usando
substance.
NBI
That is
magnificante,
lipid
pode se
droplet
identificar.
absorbed to the epithelium. Sometimes we
Mas a
can find
absorção
such
ocorre pela
finding
pele.
in
Muitas
a
vezes podemos encontrar esse tipo de
magnify
achados
NBI image. So we
usando
found
as
that
imagens
it
do
has
NBI.
very high specificity.
Temos
Sensitivity
uma alta
is 50,
especificidade.
60%,
A
but
sensibilidade é entre 50% e
specificity is more than
70%.
90% for white
E a
opaque
sensibilidade é mais de
substance for
90%
incomplete
nesse
type
caso.
intestinal metaplasia.
No caso de
So if we
metaplasia
found
intestinal.
such finding, maybe over
Diante
90%,
de um achado como
we can
esse,
say it
podemos
is
dizer que mais de
incomplete type.
90%
So it means it is
risco.
para will publish soon.
Não está publicado ainda, mas vamos publicar logo.
60%.
I have one question, may I? How
Posso
many
fazer outra?
biopsies do you take for
Quantas biópsias o senhor faz
margin delimitation for
por
undifferentiated?
delimitação da margem?
How many biopsies?
That is also very good question. So
Como é que o senhor
basically,
faz? Boa
indication
pergunta.
for
Basicamente,
undifferentiated type is
a
smaller,
indicação para o tipo
lesion
indiferenciado
smaller than 2 cm.
é
And
para lesões mais de 2 com mais de 2
showed,
centímetros.
there's a prospective cohort study. So
Temos um estudo
according to
de
study
coorte
protocol,
prospectivo e de acordo com o protocolo,
lesion larger than 1 cm,
lesões com mais de 1
we
centímetro,
took 4 quadrant biopsy.
nós fazemos uma
Lesion
biópsia de
smaller
4
than 1
quadrantes.
cm, we took 2
Menor
biopsy.
de um centímetro, nós fazemos com 2 quadrantes
So
somente.
such small lesion usually it is
Lesão
enough
pequena assim,
to exclude
são mais fáceis de
subepithelial
excluir
extension of the
em
lesion.
função da sua pequena extensão.
Nelson, may I ask one question?
Yes.
Nelson, posso fazer uma pergunta?
Hi, Nelson.
Por
Professor
favor.
Nori Uedo, thanks again for your interesting
Dr.
case
Uedo, novamente,
presentation.
grato
I would like
por seu caso interessado,
make
mas eu
some
gostaria
questions.
de
You showed that one case has
seguinte,
been
o senhor mostrou que
eradicated Helicobacter pylori.
Yes.
What is his
Erradicou
experience
Helicobacter
in detecting early gastric cancer after
Caso do câncer
eradication
gástrico
of
precoce
Helicobacter pylori?
após a
And another
erradicação do
question is,
Helicobacter
after how long
pylori.
can
Depois de quanto tempo
this happen?
isso pode acontecer?
Many observational study and also
Olha, muitos estudos observacionais
epidemiological study
e outros estudos
show that
epidemiológicos mostram
H.
que
pylori eradication reduce incidence of gastric cancer to half,
talvez seja é muito alta a
even
incidência de
initial
câncer gástrico
development
precoce,
and also secondary development. It means
tanto em
after
termos de desenvolvimento
endoscopy
primário
dissection,
quanto secundário.
H. pylori eradication reduce the incidence to about
Nós
half,
utilizamos uma
50%.
incidência de cerca de metade
But
deles,
still,
50%.
even we
Mas
follow
ainda
up
assim,
10 years or more than
num
20,
segmento
almost
de 10
15
anos,
years,
muitos deles
still
são de 15
develop
anos.
linearly.
Os pacientes
So we
desenvolvem.
have to, so there is no data
Ou seja,
when
não há
we can
dados.
finish the surveillance. So incidence becomes lower, but
Porque a
still
incidência
we need
torna-se
to
menor com o tempo, mas nós precisamos
continue surveillance endoscopy.
Continuar
That is
a
my
vigilância
understanding.
nesse aspecto, é o meu entendimento sobre o assunto.
Thank you very much.
Can I ask?
Obrigado.
Yes.
And Professor Wedo, great presentation as always.
Professor
I want to know
Wedo, excelente apresentação.
About the LCI or TXI
Quanto a LCI ou TXI,
or do you prefer white light?
o senhor prefere o uso da luz branca?
Artificial intelligence to detection.
O que é que o senhor acha do uso da inteligência artificial para a detecção de tumores?
That is also very interesting and
Outra pergunta muito
important
interessante.
question. So,
Importante também.
there is probably 3 randomized control trials
Existem 3
for
ensaios
image
clínicos
enhanced endoscopy for early gastric cancer detection. So, LCI and BLI showed significantly benefit, but we also involved in a multi-center study, or NBI did not show significant benefit. So we enrolled 4,000 patients, but still we could not show the benefit. So, but when I interpret such kind of report, it is very difficult because we cannot really blind the group. We have to, we always aware which group. So I think still, in my understanding, because we could not find a benefit for NBI for detection, so still standard detection method is good quality white light image. And probably AI must works very good. But even though we use AI, if the mucosa is very covered with mucus or, fluid, and also we did not really expand the stomach very well, even AI could not detect anything. So probably detection or diagnosis has 2 components. One is cognitive knowledge base, and one is technical base. So we have to, create good condition to make diagnosis. That is a very skill dependent, technique dependent by endoscopy. And once we can get a good condition, maybe knowledge. So in that situation, maybe AI, image enhancing endoscopy, also AI works very well. So AI solves such kind of knowledge-based issue, but still technique or skill is really depend on our hands. So
Dr. Wedo.
Yes.
In relation to evaluation of atrophic gastritis and the intestinal metaplasia and to stratify the risk, it's necessary to perform biopsies or just a visual assessment with magnification, digital chromoscopy is enough? Because in Japan, in the West countries, it's a little different. What's your opinion, please?
So that is also always we asked. So in Japanese practice, we already rely on endoscopy finding, and we are very familiar with such kind of knowledge. So probably almost no endoscopies perform biopsy for risk stratification, except research based. And actually, recently we have published the data case control study, and we apply biopsy intestinal metaplasia atrophy, Olga Olgin, and Kimura Takemoto classification, and NBI intestinal metaplasia classification, and then compare the association between gastric cancer case and the non-gastric cancer case. And we found that the best performance was a histological intestinal metaplasia. And but the Kimura Takemoto classification also almost similar this classification's performance. And the Kyoto classification was lower than Kimura Takemoto. And endoscopic intestinal metaplasia is also good, but not as good as Kimura Takemoto or histological intestinal metaplasia. Recently, we published in digestive endoscopy. So according to data, if endoscopy has enough knowledge, I think it can replace histological diagnosis. That is my belief.
Okay. Thank you very much. Thank you. It's clear.
May I? One more question.
Yes.
Dr. Uedo, do you treat H. pylori before ESCG? How is your opinion?
I think that is also still, there's no data to clearly answer that question. So some doctors say that yes, after eradication, some non-neoplastic epithelium cover the surface of neoplasia. So demarcation becomes a bit unclear. But in some case, in just a personal experience, but surrounding mucosa become clear, inflammation becomes better. So in some case, margin or detection becomes easy. So probably still controversial and there's no clear data. And one maybe data is previously we have conducted the randomized control trial compare chromoendoscopy versus magnifying NBI for delineation of early gastric cancer. At that time, we performed sub-analysis. So according to sub-analysis, even H. pylori positive patient or H. pylori eradicated patient, margin delineation accuracy was not different. So I cannot answer to your question.
Thank you. Thank you.
Maybe pro and con. Yes.
Dr. Uedo.
Pergunta aqui do auditório aqui. Eu sou oncologista clínico.
Questions from the audience. I'm a clinical oncologist, and I have a couple of questions. First one, how do you manage the situation of having a positive margin? What kind of management in terms of an endoscopic resection with a positive margin? That's the first question. The second one is the follow-up of these patients. How do you suggest the follow-up of these patients, Dr. Uedo? Endoscopy, CT scan, how often as well?
I think there's such kind of thing. How to manage is described in a Japanese guideline as well. So if only horizontal margin is positive, we can still observe. It means only horizontal margin positive does not mean increased risk of lymph node metastasis. So at that time, we can follow up and then we can perform additional treatment such as additional ESD or EMR. But if the resection margin means a vertical margin positive, it means it still can suspicious risk of some mucosal invasion or something. In such situation, we offer the additional surgery to the patient. So if only lateral margin, horizontal margin positive, when we follow up, we usually follow up 3 months later. And then if it is negative, 6 months later. And then if it is negative, every 1 year. So about 15 to 20% of horizontal margin positive patient cause local recurrence. But otherwise, 75 or 80% does not develop local recurrence. So we follow up like that, 3 months, 6 months, and every 1 year.
Casos de ressecção com margens.
Cases of resection with negative margins. What is your follow-up on that negative resection? Do you also use CT scans, CT images?
So previously expanded indication lesion, at that time there was no proof of good long-term, excellent long-term outcome. So before lesion larger than 2 centimeter or lesion with scar or even undifferentiated type cancer, we follow up every 6 months CT scan and every 1 year endoscopy for local recurrence. But recently, prospective cohort studies show very good outcome, very good 5-year overall survival for lesion larger than 2 centimeter or lesion with scar or undifferentiated type smaller than 2 centimeter. So recently, guideline did not recommend CT scan, just annual endoscopy to detect metachronous cancer.
Regarding the after ESD resection cure criteria, we have some different results outcome to SM1 invasion between Japan result and the Western countries. It's a little different. How do you explain, in your opinion, this difference? Please.
Actually, we have done some systematic review for the incidence of lymph node metastasis for surgically resected case. And we found that the Japanese data shows very low lymph node metastasis rate, but outside Japan, it has a bit high metastasis rate, like a 10% or 15%. And I discussed with my friend in the United States. So they say that usually in the United States or outside Japan, they cut only one section or a few sections for the specimen. So maybe they may miss some very deepest part or area with lymphatic invasion or something. Usually Japanese practice, even surgical specimen, for superficial lesion, cut every 5 millimeter. And even advanced case, cut every 1 centimeter. So I think it is more accurately estimate the lymph node metastasis rate. So actually, basically, for ESD specimen, we cut every 2 millimeter. So in this setting, in this condition, I think even some mucosal shallow invasive cancer lymph node metastasis rate is quite low. I guess very similar to Japanese data.
So,
sorry.
Okay, we don't have. I think you think it's not different of the ESD technique. Its evaluation of the specimen is different.
I think so. That is not so emphasized. Usually, ESD doctor only think about the technique, but how to handle and how to evaluate the specimen is very important to justify the curativity of resection. So we usually pin and cut every 2 millimeter and take picture and then measure the size of histological size as well. I think such kind of thing is also very important to complete the ESD procedure for the management of the cancer.
Thank you. Go ahead, Elix, please. Thank you.
Uedo Sensei, do you think there's space for endoscopic ultrasound to stage early gastric cancer?
So that is for gastric cancer, as I mentioned, for esophageal squamous cell carcinoma, EUS usually cause more overdiagnosis. But for gastric cancer, sometimes if we looks like some mucosal cancer by conventional image, sometimes EUS can reveal still some mucosa is remaining underneath the tumor. So it means sometimes it understage. EUS can help understage for some mucosal invasive cancer. Looks like some mucosal cancer. So intramucosal cancer, we never perform EUS because we directly perform ESD. But if we suspect some mucosal invasion, still, if we perform EUS, we can downstage the certain percent, 30% of cases, we can downstage. So they can avoid oversurgery. I think that is a clinical importance of EUS.
Thank you.
Bom, ainda temos 10 minutos.
Well, we still have 10 minutes left. I don't know if Dr. Uedo, would you like to bring additional points about his presentation? Otherwise, we may continue with this wonderful discussion here in terms of listening to questions. Professor Uedo, do you have any additional things to present there?
Or I have some.
O senhor quer complementar?
Do you want to complement something? Yeah.
I have some slides to explain my answer, so I will share.
Vamos a eles.
Okay, let's move over to them.
So, as I mentioned, histological evaluation is very important. So, we usually cut every 2 millimeter and like this. So, if it is cut interval is very rough, you may, misstage the depth of tumor invasion or presence of lymphatic invasion. So this is also data that this is United States data. So they say that the lesion larger than 4 centimeter, smaller than 4 centimeter lymph node metastasis rate is less than 5%. But if it is larger than 4 centimeter, lymph node metastasis rate is 20%. And they conclude that it can. Pardon?
Can you actually make it presentation mode, Professor Udo? Because the image is very small on our screen.
Sorry.
Oh, sorry.
Now it's okay. Is it okay now?
Yes, that's okay.
Yes,
okay.
Affirmativo.
So it is very important to, precisely cut the specimen to detect such kind of invasive part or lymphatic invasion. So the American data show that the lesion larger than 4 centimeter has a 20% of lymph node metastasis. And they discuss that it can be, such difference can be caused by genetic difference or some environmental difference from Eastern Asia and the US population. But as I mentioned, sometimes in the US practice, they cut only one part. So they may miss invasive part. So this kind of difference is seen. But if we really carefully observe the histological finding, I think Japanese data can be replicable in outside Japan. Yes. I think that's all. So that this is, as I mentioned, so if conventional endoscopy make diagnosis of intramucosal, EUS 80% is the same diagnosis, and histological finding is also the same. But some mucosal cancer, in this data, 40% is downstaged by EUS. So they can avoid oversurgery. So this is important. And recently, conventional endoscopy finding is also reported to be useful. So especially we have to if we have to insufflate the air so that intramucosal, without enough insufflation, sometimes intramucosal cancer can be elevated like this. But after insufflation, enough insufflation, intramucosal cancer becomes stretched, thin, flattened because of confined to the mucosa. But some mucosal cancer can be protruded into the lumen because of invasive submucosal cancer tissue. So insufflated air condition is very important to distinguish whether intramucosal or submucosal. I think that's all.
Excelente apresentação. Vou passar de volta.
Excellent presentation, Dr. Uedo. Let me pass the floor over to Dr. Masaru Jorge for his final comments. And if there is any other question, we would be finished in 5 minutes. Thank you.
Thank you very much for the word, and thank you for the invitation, first of all. As always, Dr. Uedo give us so many inputs and so many cues to keep going with this amazing topic. Here in our country, gastric cancer is not one of our major problems, but it's always nice to hear about and to see the developments in this field. I would like to ask something, if we have a minute, because it's something that Dr. Uedo shared with me a long time ago, and was a small black cap that they use. Are you still using that?
Yes, of course.
But what I saw was that with the optic zoom was very useful, but with the electronic zoom, not so much useful. What's your input about that with the cap and the electronic zoom?
Basically, electronic zoom is just an enlargement of the image. So if the original image does not have high resolution, it becomes very noisy or irregular. But the optical zoom really improves resolution too. So magnification and the resolution is different. So enlarged magnification image, not always high resolution. High resolution is very important because we have to distinguish or evaluate very tiny structure. So even if it is enlarged, the image is very block, noisy, low resolution. We cannot evaluate detailed finding. So optical zoom is much better than electrical zoom.
Nelson, yes?
Thank you. Dr. Uedo, last question, please. It's possible to identify dysplasia area without a demarcation line with magnification?
Dysplasia?
Yes. Sometimes we have a dysplasia in random biopsies without demarcation line. Is it possible to identify this area with magnification in BI or BLI?
I probably, in Japanese pathological criteria, there is no terminology of dysplasia. So I cannot really, correlate the endoscopy finding and the histology of dysplasia. But in my understanding, Western criteria dysplasia contain some neoplastic change, but also inflammatory, some, degenerative atopy or something. So very difficult to say. And but basically, I really believe that the endoscopy finding, if there is a demarcation line and the irregular structure, we can remove it. But only biopsy proven histological dysplasia and no visible lesion, I think we can follow up.
No, so only follow up, no resection.
No resection, okay. Yeah. Non-visible lesion, we cannot remove it.
Okay, thank you very much.
Okay, any other question from the panel? So we are almost on time.
No.
Hope to see you in Kyoto, end of 2022.
That would
Good.
If COVID situation allow.
You have 30 seconds to promote the Congress. To invite everyone to join.
Thank you very much, Professor Norio. Thank you very much, Nelson and Asadur. And I will pass for our schedule now. Rodrigo.
Hello, Thierry.
Hello. Thank you.
Bye. Thank you for your consideration, Professor Ueda.
Yes.
Professor Ueda, muito obrigado pela sua presença.
Professor Ueda, thank you very much for your presence. I'd like to thank Sadu and to all those who were part of this panel. Nelson, Luis Maruja, thank you all very much. Arigato gozaimasu.
Arigato.
Thank you.
Don't take a rest now.
Investindo para desenvolver os mais inovadores medicamentos que cuidam da sua saúde.
Faço eu agora, então, não é isso?
Na hora de escolher peça, medicamentos.
Faço eu agora.
Sua saúde merece.
Ok. Descansa.
Podemos começar?
Boa noite mais uma vez. Thierry Ponchon.
Good evening once again. Thierry.
Meu áudio está aberto?
Está aberto, pode
Seu
falar.
Seu áudio está fechado, Thierry.
Não, eu ouvi o Thierry,
Obrigado pelo convite.
Papilototomia endoscópica, um estudo de caso clínico. Meu professor e amigo Thierry Ponchon. Thierry Ponchon, ele é da unidade de Gastroenterologia do Eduardo Riot, Lyon, França. E ex-presidente da Sociedade Europeia Gastroenterologia Endoscopia. Para moderar agora e para apresentar os debatedores, eu chamo o professor José Celso Sardengue.
I would like to invite José Mendes, head of the University of São Paulo, Department of Surgery and Anatomy.
Will present for us on a case of endoscopic papillectomia that will be discussed by Dr. Joan Gornaus, a great friend who participated in the Faculty of Health, University Oberta de Barcelona, Spain. And another great friend, Professor André de Morix, full surgeon do Departamento of Surgery, Faculty of Medicina, Santa Casa de São Paulo. Regarding the dynamics of the symposium, Professor Thierry will present a complete clinical case of endoscopic papillectomy, and then the moderators will start the discussion. After the discussion, Professor Thierry will give an up-to-date on the role of the endoscopic procedures and the indication of endoscopic papillectomy. Thank you very much, Thierry, for accepting our invitation, and go ahead.
Okay, my pleasure. I'm very pleased to give this lecture and to participate to this session, and it is clearly thanks to my friend and colleague, Rodrigo Felipe. So, a great thank you. Obrigado pelo convite. So first of all, I will present the case. I hope the video will work. We will see. Okay. So I share my screen, and these are my presentation. So do you see my presentation? I hope so.
Yeah.
And this is, I think, I have to speak about ampulectomy, and in France we say ampulectomy, we don't say papillectomy. Maybe in Brazil you say papillectomy, probably, papillectomy. Yes. In France we say ampulectomy. So, in fact, I want to focus during this clinical case about complications. Why about complication? Because complications is really a major problem related to papillectomy, ampulectomy. And I can tell you that I perform a lot of ampulectomy. Possibly, I did one of the first in the world, and maybe the first one. I don't know, but a long time ago. And so I can tell you that ampulectomy is the more risky endoscopic procedure, the more at-risk endoscopic procedure. And the morbidity of ampulectomy is much higher than any other endoscopic procedure, even ESD, even US drainage. And if you think about ESD, for example, you can easily manage the complication related to ESD. You can learn, and your rate of complication decline. But concerning ampulectomy, it is not the case. It is not the case for many factors, including anatomical factors. I will explain why. So, for example, morbidity from all these data, especially the one we conducted in France, which was the only one prospective, morbidity 42%, of course, including minor complications. And this is the study which has been conducted by the French Society of Digestive Endoscopy. This is the only prospective study. Only prospective study. So you can rely on the results. So if we analyze the complications, acute pancreatitis 20%, and 4 severe out of 110 procedures, and 1 patient died, bleeding 10%, 5 required blood transfusion, and cholangitis 4%, 4.5%. Furthermore, 3.6% perforation. That means 4 cases, unfortunately only treated by medical therapy. Cholecystitis, surgery for cholecystitis, pseudocyst, and finally delayed papillary stenosis. So this is a procedure at risk. And very briefly concerning acute pancreatitis, this is a guideline from ESG published recently in endoscopy. So I of course recommend to have a look on this guideline. And as for any other procedures in the bile duct using ERCP, of 100 microgram of diclofenac or endometacine immediately before endoscopic papillotomy. So this is the basis, of course. Also, ESG recommends prophylactic pancreatic duct stenting, and in case you cannot insert a stent, other alternatives should be considered, such as high volume hydration using Ringier solution. So this for acute pancreatitis, we have some measures, some possibilities to prevent. And very well known is the use of stent to prevent acute pancreatitis, but the evidence is very low. Only around 1 randomized studies, which include a very limited number of patients, 22 patients, and you see that the pancreatitis rate when you insert a stent was null, 0, and we observed 3 cases of pancreatitis out of 12 patients without stent. So a very low evidence rate, and nevertheless it has been confirmed by other studies. And there is a systematic review anti-free retrospective studies which demonstrate a statistically non-significant reduction in rate of post-papillectomy pancreatitis. So it does work, but it is not statistically significant. And from another meta-analysis, the only factor affecting acute pancreatitis rate was the placement of a prophylactic pancreatic stent during the same session. So we recommend to use pancreatic stent even if the evidence is not so high. problem is it's not so easy to insert a stent, and some recommend to inject methylene blue pre-op papillectomy. We don't do this now anymore. And guideline in the duct pre-op papillectomy, of course, but probably it's difficult to conduct a papillectomy when the guideline is in place in the pancreatic duct. At least it was. So sometimes we fail to insert them. So these are for the acute pancreatitis. But acute pancreatitis, such as I told you, can be more or less prevented. But other complications, bleeding, perforation, cannot be prevented, and it can be observed even during a well-conducted procedures. And this is the problem. Even myself, I'm really in trouble. I'm not in trouble, but I take care. I'm really concerned when I perform ampulectomy, but because I cannot solve a complication, even if I'm quite satisfied by the procedure. Why? And especially for perforation. Perforation cannot be prevented, and this is because of the anatomy. I will explain why. So this is on you have the wall of the duodenum, the duodenal wall. In blue, you have the papilla, or the ampulla, and more exactly the ampulla. And in red, you have a tumor on the ampulla. So this is the lumen, and this is more or less the pancreas. In fact, the attachment between the duodenal wall and the ampulla is not very strong, and sometimes very fragile. And the location also is very variable of the ampulla within the duodenal wall. It can be like this, it can be like this, like this, like this, like this. Never know. And finally, when you perform a resection, of course, in this case, it looks perfect. But sometimes the ampulla is located very deep in the wall of the duodenum. And so you perform the same resection, but in fact, it is not R0, it is R1. So this is unpredictable. So never be sure that you resect an ampulla completely. Furthermore, if you have a small ampulla, which is more or less located outside the duodenal wall, and it happens, when you cut perfectly, you are very happy following resection, but then you have no more attachment, or the attachment is very short between the duodenal wall and the ampulla. On the opposite, you have the ampulla which is attached very deeply in the wall, but if you want to resect the lesion, you resect very deep, and in this case, you have also a very fragile attachment, or maybe no attachment between the duodenal wall and the ampulla. So then you have a perforation. It is also clear on this drawing. I did these drawings especially for you, and also for my team. So some points of fragility, some risk of perforation, you resect, and then you see that there is no more attachment. And furthermore, you will see during the movie, the videotape, in fact, when you inflate, the ampulla, at least the remnant part of the ampulla, disappear. And you see the bile duct and the pancreatic duct, suddenly they disappear. Especially if you inflate too much, especially if you stay too long in front of the ampulla, for example, to treat the bleeding. And then you treat the bleeding, and then suddenly you observe that the ampulla has disappeared. And then you can be sure that there is a perforation. So the case, 51-year-old woman without any risk factor, perfect conditions. She had pain and cholestasis since 2 months, and she had a bile duct dilation on CT and MRCP. Following CT, we were suspecting, in fact, an ampulla. And when we performed EUS, we did not observe any intraductal involvement, and the lesion was T1, but negative concerning SM. SM negative. So basically, a good indication for ampulectomy. So this is the case. I hope you can see it. Let me know if it is not. So this case is from my colleague, Jérôme Liro. Jérôme Liro was, you see, performed in 2016. So I wanted to show this case because of the complications. So you see a large lesion of the ampulla. I hope you can see it. Now, classic method, you use a snare, but you approach by the distal edge of a lesion. So you try, in fact, to make a loop with the snare to control, if possible, the upper part and to control, of course, the lower part. It's a 25 millimeter snare. It looks fine at the distal part, at the anal part, but we need to be sure that we take the whole lesion at the upper part, which seems to be the case. You see, we don't take only the papilla and the lesion, we take the whole ampulla. So in this case, you're happy, despite the lesion is quite large. No? So it seems to be good. Undercut, going quite fast, and then perfect. It seems that you see already the pancreatic duct and the bile duct. Then immediately you should remove the specimen because the risk is that the specimen can go further into the denum of the jejunum. Now then you analyze the resection site. That we observe large opening of the bile duct and the pancreatic duct. But you already see a small aperture here at the lower part. Is it a real transparietal perforation? We don't know. Possibly. Then insertion of a pancreatic stent, a 5 French, single pigtail. You already see that there is some bleeding. Bleeding is very frequent, as you know. Now, bleeding seems to come from the right side, anterior side. We use you can use a quite forceps, but in this case we use only hot biopsy forceps, which was effective. So the bleeding stopped, the stent is in place, but then there is maybe perforation. Sometimes the perforation is on the left side, sometimes on the right side, more frequently on the left side, that means on the posterior part, and sometimes exactly at the lower part here. So possibly it is transparator, then we close the perforation by clip. In this case, it is of course impossible to use a large, for example, OSCO clip, because the risk is to, of course, in the clip, to catch the pancreatic duct or the bile duct. Okay, so you can only close using small, regular clips. And you see several clips has been inserted. My colleague wants to secure the closure, so it closes also on the anterior part. And finally, if you look carefully, it seems that the papilla, at least the rest of the ampulla, tends to disappear a little, okay? Tends to disappear. You don't see very well now the bile duct. So this is the effect I spoke about before. But maybe because of inflation, you take some time to close, you take some time to stop the bleeding, and then progressively, the bile duct disappears. So at the end, you see 5 or 6 clips to secure. But at least, thanks to the stent, the pancreatic duct has not been closed. So it looks quite satisfactory, but in fact, when you perform such closure, you are never sure. It's not like a stitch. You just rely, of course, on clips. And you see one clip is, of course, not in place. Maybe this one is not perfect. So this is the case. I hope you perfectly see the case. Now the follow-up. And really, this case is emblematic. This case is emblematic of all problems you can observe when you perform a papillectomy. During the follow-up, finally, retroperitoneal drainage, surgical drainage, was necessary 1 day later because of retroperitoneal abscess, not really an abscess at the beginning, at least air and liquid in the retroperitoneum, very painful for the patient, of course, demonstrated by CT, and the patient had a retroperitoneal drainage, which was effective. Just the drainage was sufficient. Then, at histology, it was a T1, not a T1 limited to the mucosa, it was a T1 submucosal carcinoma, which is not totally surprising if you look at the lesion, which was quite large. And finally, the patient had a Whipple resection. So at the end, this case clearly, in fact, is interesting for 2 reasons: complications, bleeding, perforation, and also the fact that even EOS was not so effective. And in fact, clearly, in fact, EOS is very effective to look for intracanal into bile duct or the pancreatic duct invasion, but it's not so good to detect submucosal carcinoma. So finally, the patient had a Whipple resection. Now she's fine, but finally, ampulectomy could have been avoided, and at least ampulectomy was clearly at risk for this patient. So this was the case. So now we can discuss the case.
Thank you very much, Thierry, for the nice presentation.
I stopped to share the screen. I will come back on the slideshow later. Okay.
Okay. Thank you very much, Thierry, for your fantastic presentation about one case. This is a really interesting case because, for example, in the last week, we had a 60-year-old male patient with a duodenal papilla ablation, whose the biopsy was negative, but the echo endoscope revealed the same findings that you encountered in your case, without invasion of the bile duct or the main pancreatic duct. It was, and we indicated the endoscopic papillectomy in the diagnosis of adenocarcinoma. This is really the great doubt. What is your conduct? And to discuss this case, I call Dr. André de Morix. I would like some comments about this case and what's your opinion in the case of Dr. Thierry Ponchon. We need to perform the Whipple procedure or the follow-up in this patient. What do you think in the case of adenocarcinoma? I can hear you.
Is off.
Thank you for accepting our invitation, André.
Okay, Kate. First of all, I would like to thank the organizing committee for the invitation. It is a great honor to be discussing between so very eminent endoscopists and gastroenterologists in this field. So it's a pleasure to be here. So, and thank you, also my friend, for the invitation. And I'd like to applaud Dr. Ponchon for the case. It's how did you manage the complication with those clips? It's incredible to see. Like a surgeon, you almost did papillary sphincteroplasty. Almost an open papillary sphincteroplasty, but it was an endoscopic papillary sphincteroplasty. So my first question is, when you analyze this case and you put this small lesion in the consensus guidelines, this recent consensus guidelines that you show it's a perfect lesion to be endoscopic treated. Okay, And I didn't hear if you did a previous biopsy before the ampulectomy. Did you perform a biopsy? That's my first question.
Not our team, but the colleague who referred us the patient did biopsy. Nevertheless, the diagnosis was obvious, at least microscopically.
Why I'm asking this? Because there is a range of false negative in core biopsies and small biopsies. You know that primary in adenomas, we got a 20-30% of degenerated lesions. So that's the first question. And these biopsy are usually necessary in consensus. They put that it's a good procedure before to decide ampulectomy. So if I had a biopsy and was negative, and when I do an en bloc excision by endoscopy, and I saw not the complication, but a carcinoma with submucosal invasion, I think because the risk of oncologic, not a real oncologic procedure, I think the Whipple is the indication after the resection. This is obvious. What is the question is, could I previous by US or some endoscopic signs, not like ulcer, rigidity, extension, but submucosal invasion in the US, in a lesion under 2 centimeters. There is any sign I can prevent an ampulectomy in this case and go straight to a Whipple procedure? That's my first question as a surgeon. And the second one is in Whipple procedure we have a complication as well, and we got an ampulectomy. That's a risky procedure, but it's less complications than a Whipple procedure, probably, which is a minor procedure when you compare it to a Whipple procedure. But when when you have this kind of a complication after the endoscopy, perforation, and pancreatitis, doing a Whipple procedure after these complications is not easy as well. And this is going to raise the Whipple complications. After an abscess and after pancreatitis, we get 10% of pancreatitis after an ampulectomy, 2.5. This is not too much of a cholangitis, and bleeding you can manage. But pancreatitis and abscess on perforation, when you need to procedure Whipple after the ampulectomy, that's going to be a problem for the surgeon and a problem for the patient as well. So that's, I think, it's the point. It's the when you go to pros and cons of this procedure. So that's
You're right. That's why I want to advise my colleagues that they should really take care when they perform an ampulectomy. So at the end, I will have a short summary of the last studies, 10 minutes. So you will see that even more the diagnosis, of adenoma is not easy.
Yes.
And so you should be modest. And even an expert, I can tell I am an expert, but I'm not frightened, but this is for me the more at risk and the more tricky procedure. And also because of the diagnosis, you're right. Because in fact, the lesions can be located in the ampulla itself. At least maybe the carcinoma is located inside. This is not like a regular adenoma in the colon. Of course, when you have a very difficult LST, villus lesion, it's sometimes difficult to find the carcinomatous component. But in this case, the carcinomatous component can be really inside the ampulla. You don't see it. EOS is far to be perfect, 80% of accuracy only, so you can miss a carcinoma. And first, I agree totally with you. Then we also take the risk that finally Whipple resection will be more difficult because we have the complications. So that's why at least we should inform the patient carefully about the risk. And I am very frank to the patient. I tell to the patient, there are risks that I cannot control, but the gold standard is to perform ampulectomy because, nevertheless, in the large majority of cases, we will avoid a large surgical resection. But that's all I can tell to the patient.
Joan Gornaus, do you have to do some comments about the presentation?
Hello, thank you very much, Zeus, again, to invite me in this in another meeting. And the presentation of Dr. Ponchon was magnific. I enjoyed. It was a very illustrative presentation and very teaching, because it's very important that the endoscopists show the successes and the adverse events that are related to these risky procedures. So I think it's a very nice clinical case to discuss today. And first, I would like to discuss about the terminology and ask the opinion of Dr. Ponchon and Dr. de Moritz between the papillectomy and ampulectomy. I know in my center in Barcelona, my surgeons say that the endoscopist cannot perform an ampulectomy because the snare only can cut the elevated portion of the papilla. So because the ampulla, the presentation that Dr. Ponchon, the drawings and the picture were very nice, and the ampulla, the resection of the totality of the ampulla, in my opinion and in the opinion of my surgeons, is not possible with an snare. So I think that the endoscopist only can cut the papilla and we can leave the deep portion of the ampulla. No? So, well, it's an academical term, no? But maybe if the difference between endoscopic papillectomy and surgical ampulectomy is different. In this case, maybe Dr. de Moritz could think that it would be better surgical ampulectomy, because the surgeons can, after the resection, they can make a suture, no, of the PD, the pancreatic duct, and the CVD in order to prevent this perforation. No? So in my experience, I think in this case, maybe the lesion was between 2 centimeters of ledge, more or less 2 centimeters without intraductal growth invasion. So if the biopsies are negative for carcinoma in situ, in Barcelona, I will do the same procedure, a papillectomy using an snare. And I think there is a bad luck because the perforation was very huge. And one of the questions I would like to ask to Dr. Ponchon is, do you think that a fully covered metal stent, a biliary metal stent could prevent maybe the retroperitoneal abscess in order to facilitate the drainage of the bile direct to the duodenum, not to the retroperitoneal, because the ampulla is very, challenging site when every day flows more than 2 liters of fluids. So I don't know what's your opinion, because maybe in my center, after the 4 or 5 clips to close the perforation, the hole, I think that I would like to put to insert a fully covered metal stent.
Okay. Thank you very much for these 2 comments, 2 questions. As a comment from Dr. Dominic, they are excellent. And the first comment about do we perform ampullectomy? Do we perform ampullectomy? I think this is a great comment. Of course, this is not ampullectomy, because if you perform ampullectomy, you always have a perforation. But this is not a papillectomy, because when I saw the first, for example, when I saw, nothing against my American colleagues, but when I saw some colleagues in the past performing such resection, they just resect the papilla, the small aperture with papillomatous pattern. So, of course, they did not resect anything. Okay. At least, I think it is a partial ampullectomy. It's a partial ampullectomy, and the problem is that we never control the depth. We don't well control the depth of the resection within the ampulla. Nevertheless, R0 is obtained quite frequently, in fact, paradoxically, of course. It is not as good as when you perform a resection in the colon, you perfectly know if you have a complete resection with R0. Not in this case, you don't know, and you should rely on the pathology. And sometimes you are surprised because you think you resect a large lesion, and finally the lesion is quite small. So I think it is a partial ampullectomy. But it's a great, I think it's a very interesting discussion. Now concerning the stent, I agree, it could be a possibility, but we are using stent in case of retroperitoneal perforation following papillotomy, sphincterotomy, which are rare now, nevertheless, and it works. But in this case, you see that the location is different. I'm not totally sure that the stent will cover the perforation. Yes, the stent will probably avoid the bile to stay close to the perforation. But I see some drawback with the stent, because if the patient bleeds, then with the stent in place, you will be in trouble if you have to stop the bleeding. So it's not so simple that for retroperitoneal perforation following sphincterotomy.
Thank you very much, Thierry. André, do you have some question? We have one minute more. After Dr. Ponchon will present for us an up-to-date to endoscopic papillectomy.
Okay. I will finish. I'll be quick. It's going to be a quick question. And there's semantical problem of ampulectomy or papillotomy that Joan pointed. I think when you get an ampullary lesion, I think that is not a lesion to be resected by endoscopy. And when you see inside growth to the ampulla, it not should be resected by endoscopy. I think the protrusion area, the end of an ampulla, the protrusion area that is called papilla, that's the lesion that should be treated by endoscopy. And you can see by the exams and the endoscopy this division. And I think what is the risky part, and that is how the expertise of the endoscopists and the experience of the guy that is doing this is that blind part of the procedure on the that you can see or at the end of the snare behind the injury, and you put the ring and you close the ring under the injury, and you have the end of the bile duct and the end of the pancreatic duct. This transition, that's the point that you got the risk of the perforation. And always in this kind of not close lesions to the ampulla, but the ampullar lesions, if you can see in front of endoscopy, on side endoscopy, you can see this blind part of the procedure. That's the risky part. And in that point that you're gonna have bleeding and you're gonna have a risk of perforation. And that you show us and brilliantly solution and a brave case to go inside and treat like you try to do. So okay. That's my comments.
Thank you very much. Now, Dr. Thierry Ponchon was... Oi.
Professor Celso?
Oi. Tô te ouvindo.
I can listen to the question if there is a question.
Now, Dr. Thierry Ponchon has 10 minutes to present for us an up-to-date for the endoscopy procedures in endoscopic papillectomy.
Okay, so I based this update on the guidelines recently published by EAG, and I made some comments, okay, with the literature. So first of all, diagnosis. Of course, we should be very cautious. I will explain why. EAG recommend is of course histological confirmation by endoscopic biopsy. This is obvious, but it is more obvious for ampular than for any other lesion. And EAG recommend follow-up with an EOS, side-viewing endoscopy, and further sampling with repeated biopsy if the histopathology is initially negative. So be sure that it is a real adenoma. So this is the main message. And even more, EAG suggests to perform endoscopic ultrasound FNA and sometimes limited sphincterotomy with repeated biopsy. You are never sure. So never rely, for example, never rely on the first specimens you got. It means that the histopathological diagnosis is very difficult. And why it is difficult? For three reasons. In 30% of cases, the lesion is asymptomatic. And finally, the lesion is quite small, and you don't perform adequately biopsies. You perform biopsy with a regular endoscope, not with a dual endoscope. So the risk to miss the diagnosis is quite high. In 30% of cases, the lesion is really endoampullary. The lesion mimics an impacted stones, so then in this case you should perform EOS FNA or papillotomy. And these are three situations. Of course, when there is a ulcer-related cancer, this is an indication for surgery. When it is exophytic, not difficult to perform an ampullectomy. When it is endoampullary, you don't see anything, and probably this was more or less the case I presented. And finally, the diagnosis, precise diagnosis, is very difficult. So when to make biopsy following papillotomy, in case you need to perform papillotomy, 2 weeks later in order to avoid artifacts related to electrocoagulation, because there is a risk of misdiagnosis between low-grade dysplasia and electro lesions related to electrocoagulation. And the third reason is clearly for the pathologist it's also very difficult. You have great experts, and unfortunately you have some pathologists that they are not very familiar with the ampulla. And so there is a very low inter-observer agreement. And in our unit, we always ask a second lecture by our expert pathologists. We never rely on the analysis performed by a pathologist. We don't know the expertise. And in our studies from the French Society of Digestive Endoscopy, we perform 93 ampullectomy or papillectomy, and we had 14 false positive adenomas, endocrine tumors, adenomyomatosis. This is also a problem with the pathology, hyperplasia, inflammation. So, because this was a multi-center study, and probably expertise of the first pathology was not so good. So that means high-risk procedure for nothing. So histopathology never rely, be sure and be confident, take care about the expertise of pathologists. Staging. ASG recommend EOS and of course MRCP. Also, ES suggests to use maybe intraductal ultrasound, okay? But in fact, it is costly with some risk of pancreatitis, so it is not really recommended, it is suggested. And in case you have an intraductal extension, of course, in this case, you have to go to surgery or maybe to perform radiofrequency, but you can only perform safely endoscopic papillotomy if you have no intraductal extension. And as we already reported, when there is an invasion of the mucosa, there is a risk of lymph node invasion of 30%. So in this case, you should perform Whipple resection. But this is very difficult to analyze using EOS. So intraductal involvement, you see from the resection, and suddenly you see a piece of tissue arising from the bed, and more. So this is intraductal involvement. In fact, it has clearly demonstrated by makers 15 years ago that endoscopic resection was curative in 83% of cases without intraductal involvement and only 46% with. And furthermore, there is a risk of recurrence from the death. So we can use standard EOS. Maybe IUS, intraductal, is also interesting, such as in this case. IUS is also interesting to look for the invasion of the mucosa. So the mucosa and the submucosa is a whitish part here, a whitish layer. So in this case, it looks it's not so easy a procedure, not easy to analyze. It looks normal here, but here you see that there is the submucosa is very thin and invaded, and it was a T1 submucosa. So, in fact, the problem is, as I told you, the sensitivity and specificity of EOS is better than CT, MRI, and US, of course, but it is not perfect. Only 77% sensitivity and accuracy for IUS, but at the risk of pancreatitis, is a little better than EOS. So things concerning diagnosis and staging, we are far to be perfect. And concerning intraductal extension, now the treatment, yes, suggests the use in expert center of complementary techniques, thermal ablation by cystotome or radiofrequency. But the extension should be less than 20 mm. So these are the first techniques. Cystotome inserted on the guide, and you see that, in fact, at the end, they observe when they treated the patient, no difference concerning the resection rate if the patient had intraductal extension or no intraductal extension. So it seems that this technique is interesting, but limited number of cases, and containing radiofrequency, which is now more popular. 14 patients, you see, and they insert a prophylactic stent because of inflammation, and they observe treatment success of 92%, but on a very limited number of cases, and some morbidity. Delta structure, 5 patients, retrodural abscess, 1 patient. So it's not so, it is far to be safe. And more recently, another study, 20 patients, randomized studies, but only 20 patients, and 70% dysplasia eradication at 12 months. So, but the main premise is related to biliary structure, requiring temporary biliary stenting, 20%. So it is, I think, not recommended. It is suggested, and frankly speaking, we need more data. And finally, follow-up. This is also a very important part of my topic. Never be sure. And ESG recommends long-term monitoring of patients for at least 5 years. Every year, within the first 3 years, and then you can enlarge. But 5 years, why 5 years? It is based on our prospective studies, mean for 36 months. We perform finally R0 ampulectomy. R0, where R0, 89%, and some patients died of unrelated disease without recurrence. Success 57, but late failure 5. Even if the ampulectomy was R0. And you see, at 7 months, 12 months, 2 at 24 months, and 1 at 3 years. Probably because we still have some small remnant of tissue, for example, in the pancreatic duct. And finally, 1 at resection, 1 was treated by iron, and 1 had no complementary treatment because they were not operable. And if you have a recurrence, you can use APC, you can use EMR. It is suggested by ESG. Nevertheless, efficacy of endoscopic treatment after residual or recurrent lesions runs from 38 to 100%, with several sessions being required. So, to conclude, never when you perform ampulectomy or when you attempt to perform ampulectomy, never be sure about the initial histology. Never be sure that you will be safe. You must inform the patient because of anatomical factors. Never be sure that even if the resection is R0, that there will be no recurrence. So we should, at least for this indication, we should stay very, very, very modest. Thank you very much.
Thank you very much, Professor Thierry Ponchon. Was fantastic, your 2 presentations. I think the discussion was really good. The terms of endoscopic papillectomy or endoscopic ampulectomy is we have a really many doubts, but this is a term. The great problem is if you take one patient with an bulging of the papilla, we perform the endoscopic papillectomy even after we are surprised with an adenocarcinoma. This is a great problem for us to indicate it or the WIPO or the follow-up. But thank you very much for your fantastic presentation. I think we move on for the I don't know, bye for all. Thank you very much. And I think we'll move on for the another section. Dr. Rodrigo Felipe.
I learned a lot too. Thank you very much.
Thank you very much.
Thank you, Dr. Ponchon. It was a pleasure.
Thank you, Juan.
Vamos dar Juan.
Thank you.
So let's now continue with the session, right? Yeah. Thank you, Thierry, Andrew. Andrea, thank you very much. Thank you for your comments. They were excellent, okay? Right, thank you.
Probide é a melhor escolha entre os probióticos. Probide tem a exclusiva tecnologia BioSupport, que garante a resistência das cepas ao ácido gástrico, entregando-as vivas ao intestino. É o primeiro probiótico com alegação funcional aprovada para auxiliar na redução de complicações gastrointestinais, dor abdominal, náusea e vômito. Além de ser o único com atuação no eixo cérebro-intestino, comprovada por estudos clínicos, auxiliando no alívio a sintomas gastrointestinais relacionados ao estresse, equilíbrio e bem-estar para uma vida mais saudável. Probide, único com atuação no eixo cérebro-intestino.
Alô, boa noite a todos.
Okay, now good evening, you all. Marcos, Clarencio, now, in order to continue our third international seminar of endoscopy, gastroenterology of Itaigara Memorial, now still talking about biliopancreatic diseases. We now have a presentation of a clinical case by Professor Louis Demestier. Actually, he will speak about the pancreatic endocrine tumor, where we are and currently where we may go. He will present initially a case. Professor is of the Department of Gastroenterology and also Pancreatology of the University Hospital of Beaujon in Clichy, France, Paris University. And we will have in the discussion as moderators a well-known Professor Celso Ardengue, who you may introduce, please.
The neuroendocrine tumors and the pancreatic gland, and this is the really discussed in all of the journals of the meetings for this case. And the Dr. Louis Demestier go on to your clinical case to present and discuss. Thank you very much for accepting.
Just if I can, Jose, if I can say something. Just a word before. First of all, good evening to all of you. It's a pleasure to be with you tonight to discuss this very interesting topic. If it's possible, Louis is going to present the cases, and just afterwards, I will give the talk so that we have all the data and then discuss all together. If we can slightly change.
Okay, Philippe. Okay, you could coordinate. Okay, no problem for me.
Louis, the floor is yours.
Okay, you are a great friend for a long time.
Okay, so thank you very much for this very kind invitation, and I'm really pleased to present you these two cases regarding the watch and wait strategy for small pancreatic neuroendocrine tumors, and I will present you two clinical cases. The first clinical case is regarding a 63-year-old female patient which has history of type 2 diabetes, autoimmune thyroiditis, asthma, and also a mild chronic kidney disease. And in September 2015, she presents with nephritic colic, and for this reason, she's referred for contrast-enhanced computed tomography scan. And this CT scan shows, which is probably not related with the symptoms, a 12 millimeter contrast enhancement located within the pancreatic body, which makes the suspicion of a pancreatic neuroendocrine tumor. Afterwards, endoscopic ultrasonography is performed and will show a rounded, well-delimited mixed lesion with very strong and very typical vascularization with a really homogeneous contrast enhancement which is very typical. And also this EUS examination will not show suspicious lymph nodes, no pancreatic duct dilatation. And during this procedure, a biopsy of the lesion is performed. Histopathological examination of this biopsy shows a very typical, well-differentiated neuroendocrine tumor, along with both the histopathological aspect of cells and also with the positivity of the two main immunohistochemical markers, which are chromogranin A and synaptophysin. Besides, because the Ki67 index was very low, here less than 1%, well, the patient was defined as having a PNET grade 1. Expert multidisciplinary team discussion took place a few weeks later, and in front of this typical pancreatic G1 net, which was clearly incidental with no relation with symptoms. And I have to precise here that there were no hypercalcemia and no suspicion of hyperparathyroidism, which could have been possibly related with multiple endocrine neoplasm type 1. Also, there was no suspicion of functioning syndrome. The morphological characterization was really typical. There was no pancreatic duct dilatation, but we also noted that we had no notion regarding the evolution of these pancreatic nets. So for further characterization, the patient underwent a 68 gallium Dotatoc PET-CT, and also we wanted to know a little more about the follow-up for the evolution. This PET-CT was performed, and as shown here on the screen, on the image, there was a very strong and very homogeneous uptake, which corresponded to the pancreatic lesion. In fact, we realized at that time that the patient had performed CT scan already 3 years before, which means in 2012. And at that time, the pancreatic lesion was already here, but in fact, it was not reported at that time. So thanks to this previous CT scan, we could observe a perfect stability of this lesion over 3 years. Hence, we decided to go for simple follow-up. And we also checked that the lesion was well detectable on MRI, on pancreatic MRI, which was very suited for the patients which had a chronic kidney disease. And so following regular annual MRI surveillance, we could observe that for a quite long period of nearly 10 years now, the patient has a very perfect stability in time, along with an excellent quality of life. The second clinical case I will present here is that of a 55-year-old male patient. And this patient had the particularity of having a very heavy cardiac past history with a coronaropathy, also blood pressure problems, but also cardiac insufficiency and a defibrillator. He had a past smoking history also, and in around the same time in September 2015, he visits his GP for loss of weight, and standard blood tests were unremarkable, along with standard gastroscopy and colonoscopy, which only permitted for the resection of 3 polyps, which corresponded to low-grade dysplasia. CT scan was performed and showed quite with kind of difficulty this partly cystic lesion located within the pancreatic tail, which measured 16 millimeters with a moderate peripheral contrast enhancement, but with no other lesion on the CT scan. Endoscopic US was performed and showed once again a very rounded and well-delimited lesion, but which was mixed with both a solid and also a cystic central component. The peripheral solid component had also an homogeneous contrast enhancement, which was quite typical of neuroendocrine tumor. And there again, there was no suspicious lymph nodes, no pancreatic duct dilatation, and the biopsy of the lesion was performed. histopathological examination was quite difficult because of few pathological material, but the pathologist was positive on the presence of a well-differentiated neuroendocrine tumor with chromogranin A positive and synaptophysin, which was more or less positive also, but with some traces. And there again, in view of a Ki-67 of less than 1%, the tumor could be classified as grade 1. During this expert MDT discussion, there we was quite a little more annoyed because of some kind of possibly annoying features, because in one hand, the pancreatic had a grade 1 at histopathological analysis of the biopsy, and the discovery was absolutely incidental with no relation with the weight loss. There was no suspicion of functioning syndrome. And although EUS could brought us a quite typical characterization, the lesion was partly cystic, and there was only a moderate enhancement on CT scan. Also, the size of the tumor was 16 millimeters, which was not very far from the 20 millimeter threshold that we usually have to use for a decision of surgery. However, the patient had a cardiac history and was very known for frailty, and we had no notion on evolution. That's why we decided to go on for further characterization with, once again, a gallium dot-atomic PET-CT, but here also a FDG PET-CT, which could bring some additional information regarding prognostic characterization and also follow-up for evolution. On the gallium dot-atomic PET-CT, we could observe a very typical strong and homogeneous uptake with no other lesion detected. Of note, this very strong uptake was similar to that of spleen, which corresponds to a Krenning grade 4. The FDG PET-CT is always interesting because we know that uptake on FDG PET-CT can be correlated to the pathological Ki-67 index evaluation. And when we have a doubt regarding the potential aggressivity of the tumor, it can bring some additional information. And here in this patient, this FDG PET-CT showed no uptake of the lesion, and also no other lesion could be detected. So 1 year later, we performed a new CT scan, and we could see that there was no evolution after 1 year follow-up of this pancreatic tail lesion. Cardiac disease was stable, and because of the frailty and despite the young age, we decided that the benefit of the risk of the surgery outpaced those of the benefits. So we decided to go on for simple follow-up once again, and 5 years later, the patient had stable cardiac disease, and while we were observing a very minimal evolution, because the lesion is now measuring 17.1 millimeters, the patient has excellent quality of life, and we keep on proposing simple surveillance. Thank you very much for your attention.
Thank you so much, Louis. I think we can go on. If I can get the... Should I put my slide myself, or do you?
Yeah, Philippe, I would like to send for discuss with Dr. Felipe Coimbra. Felipe Coimbra is a surgeon here in Brazil. I think this is really interesting to know the opinion of him about this two cases. What do you think?
Okay.
Okay.
Okay. Thank you, Celso. Thank you, professors. Oh, very nice cases, and I agree with the decision in these cases, and I'm sure you're going to see more details in professors' classes talk now. But just a few comments. I think 3 main points you should observe and pay attention in these cases. I think one is, of course, the imaging. If the lesion is homogeneous, very well limited, the size, of course, the behavior during the time, if possible, to compare. Second point is the pathology. Of course, it's well differentiated. situation, so we can think on observing. And the third situation is about the patient, and the surgery is going to be necessary to treat the nodule if it comes to happen. So I think with these main points, I think we should offer this possibility. We like a lot to talk with the patient and explain both possibilities and take the decision together too. So that's a kind of thing we like to do. And of course, it depends on the side of the patient, on the not on the age, by the frailty, the risks of the surgery, if it's on the head on the tail. So everything should be considered during this decision-making process. But I think these are the main points. I think these are great examples. We should also pay attention a little bit more on the lesions more than 1 centimeter, between 1 and 2 and 1.5 and 2, because they have a little bit more risk of lymph node metastasis, even if they don't show up. But I see no problem in observing these patients, because it's not a definitive conduct sometimes. If you see an evolution and you see something different, you usually have enough time to change and operate on this patient. So I think that's it. And I'm sure I'm very glad, and I'm looking forward to see Professor Felipe's talk too. So these are my opinions and my main considerations. Thank you, Celso.
Thank you very much for your comments, Philip.
Thank you, Felipe. So what should I do with the slides? Should I share my screen?
Okay.
But I don't see. I tried to share my screen, but do you have the slides?
No.
I sent them this morning. Okay, let's see what happens here. You don't see the slides, I think, now.
No.
I do, but I don't know what happens.
Louis, I would like to do one question, only one question for you. What is the decision weight of the PET data talk in the management of an PNET G1?
Yeah, that's a very good question. I think that there is both interest regarding the prognostic evaluation, because we know that a very strong and homogeneous uptake is correlated with good prognosis. And also, I think that it is of particular interest in lesions that are maybe a little large, and for which we believe that there is a risk of lymph node metastasis, because the decision of surgery is always due to the fact that there is a risk of lymph node metastasis and potentially also distant metastasis. And so we know for now that this is the examination with the highest sensitivity for achieving a very precise workup.
Okay. For example, in all patients with you find, for example, a little nodule in the body of the pancreas or in the tail of the pancreas, do you perform the EUS? If you perform the EUS, you perform the EUS FNA or EUS FNB. What do you think about these two techniques?
I think that molecular studies and molecular techniques are very on the edge of development and will be more and more useful for patient prognostic stratification. And for this, for example, for very new markers such as DAX, ITRX, maybe PDX1, IRAX also, which can classify between alpha-like and beta-like intermediate tumors, we will need more and more material. And that's why I think that the largest the biopsy here is, the happiest my pathologist will be. So I think that this is very important for patient stratification. And also, despite the development of, for example, a Dotatok PET CT, which can highlight the neuroendocrine tumor nature of these nodules, we could say, but why do we absolutely need a biopsy? And I think that this is the point. This is the reason. For now, we do not have any liquid biopsy. And so we still need some pathological material. And that's why I believe that biopsy is still important.
In your service, do you use the cytology or the microhistology to analyze the material obtained by EUSFNA or EUSFNB?
More and more, the most informative will be microhistology.
Microhistology.
Yeah.
Felipe, do you have some question? Between Dr. Philippe Huzniewicz is ready for presentation for us.
I think it's coming.
Okay.
I should arrive from what I understand, but just probably 1 or 2 minutes more.
If I may add something during the meanwhile, I would say that pancreatic surgery is always a big deal for the patients, as we all know. And we also know that within the spectrum of all the pancreatic neuroendocrine tumors, it can go from quite aggressive tumors, which can be prone to distant metastasis, but it's always more difficult not to operate the patients. It's always difficult not to be invasive. And I think that this is one of the hardest parts of our job, is to decide to do nothing and just to go for surveillance. And I think that these little sporadic incidentallomas neuroendocrine are a very good example for this.
Okay. Felipe, do you have some question?
I'm sorry, because I don't understand what happens. I think you have my slides. Maybe you could use them, because
you sent for us. You sent for the organizer committee the slides, Felipe.
Yes, I did.
Ok. Rodrigo, acho que então seria interessante passar os slides do Dr.
Rodrigo,
Felipe.
so I think it is interesting if you can actually change the slides, Dr. Felipe's slides, because he cannot do that, or Marcus or Felipe. Can you hear me? Do you hear me there?
It's saying that the slides are being prepared and nothing happens afterwards.
Felipe.
Felipe, are you there, Marcus? Can you hear me there? You in the auditorium, in the main room?
It's the first time it makes this. I don't understand.
Celso?
Oi,
nós estamos sem os slides.
Celso, yeah, Dr. Felipe, right? Is this Dr. Felipe Rusniak? But he may share but he is not being able to share. That's the point.
Felipe, sharing your screen, please, now.
I stop sharing my screen?
Yeah, stop your sharing. Yes. Ok. E agora, vê se o pessoal daí tem a...
And now, please check if his slides can see there. What?
Felipe.
Can you try again?
So preparation of the slides. It indicates that I'm sharing my slides.
Yeah, sharing, but
the slides do not appear, by the way.
Yeah. Marcos, você está vendo aí se o pessoal tem?
Marcus, do people have visual access to the slides, Marcus?
Alô, Celso?
Celso? Yes. A couple of minutes ago, Felipe shared his slides, but then the image disappeared.
Mas fechou.
Stop your PowerPoint, and after to reopen your PowerPoint and try to share with us.
But I did that.
Yeah, I think
But
so.
You cannot use the slide that I sent.
Marcos, o pessoal daí da técnica não tem os slides dele? Ele falou que
Marcos, technicians, don't they have the slides here? Actually, the technicians are saying that he did not send the slides.
So he said that...
Então abre aí para a gente ver. Abre aí essa apresentação aqui que foi enviada.
Essa apresentação
abre aí para ver se é essa.
I'm checking the presentation that has been sent, because there is one by Louis and the other one, and Philippus as well. I think this is Philippus. Yeah, there you go. No. This is Dr. Louis de Mestier. No.
This is mine.
Não, this is the Louis de Mestier. Deve ser a outra, então. Deve ter uma outra aí.
Não é.
Possibly there's another one.
Não, essa é a do Louis de Mestier. Deve ser da outra. Deve ter uma outra.
There must be another one, right?
Não é essa. Pode...
No, this is not it. This one can be unshared.
Tirar essa aí, Jaime.
You should close this one, probably. Okay. I'll try again to share.
Yeah.
E vai ter que compartilhar, Celso. Eu não sei se está tendo alguma dificuldade, enfim.
Ele está tentando.
Yeah, he's trying that.
So it comes always to the same. Impossible. It says it's impossible to...
Ok.
Quer tentar mandar? Would like to send
abrir para ver se é essa, Celso.
Minutinho.
Ele vai abrir outra,
Just a second, another one will be open right now. Let's see.
No, essa não.
No, that is not it.
Okay, I think so.
No.
So thank you for the opportunity.
Não, essa daí não.
No, that's not it.
Pede para ele mandar para você agora.
Can you ask him to send it again? You keep talking while this one arrives.
By email, and I share for the audience. What do you think?
Nevsky, envoyez-la moi, je vais vous passer les diapositives.
Oui, passe-moi les diapos. Oui.
Enviar para o Luiz.
Felipe, vai coordenando aí, Coimbra. Vai coordenando.
Do coordinate it there, right?
Question to you, Luis, now another.
Sure.
About the second case, I think it was a little bit different, not only because of the size, right? It was a little bit larger, it was 1.6 millimeter, but it was also an heterogeneous lesion, maybe a cystic or with necrosis, we don't know exactly. It was clear in the imaging and the CT scan, I think. And so this was the first point. Do you think we could, by the echo endoscopy, say it was like a cystic? Because we have like a external parenchyma or something different.
Like a ring,
so
yeah.
This was a point of discussion on observing, on operating, because it was an heterogeneous lesion. The second question was about using PET-CT, the FDG one. Because usually, at least as we use both PET and Galio when you have like a G2 or G3, usually, not a G1. So why you took this decision? Just for us to understand, of course, and learn from you. And would you do it different, or it was on like specifically for that case?
These are two very, very good questions. For the first one, regarding the cystic lesions, we have thought for years that cystic lesions might be associated with a poorer prognosis. But in fact, more recently, we had a very nice study showing that, in fact, there was no particular prognostic difference. That's why for now we are managing all cystic lesions exactly the same than for non-cystic lesion. For the second point, regarding the FDG PET, and you are absolutely right. For years, we have mostly used this for highly proliferative lesions, especially G2 or G3 lesions. However, in more recent papers, it was demonstrated that the prognostic impact of FDG PET-CT was clearly independent from the pathological grade, and that in fact, approximately 40% of G1 pancreatic nets also have uptake at FDG PET. And this is important because it can make some kind of non-invasive prognostic evaluation that can be very useful when you hesitate between two strategies. For example, which lesion am I going to biopsy? Of course, I'm going to biopsy the one that is FDG positive. Am I going to make simple follow-up or surgery? And this can also bring some kind of information.
Oh, very good. Yes, very, very good information now. And by the way, just following on the conversation, and I think that's a very important point here you showed very well, was that it's not only about the size, right?
Yeah.
Size is only the beginning. You should try as much as you can, try to take more information on the PET or behavior along the time, biopsy, and the imaging characteristics you see. And of course, it's very also important to check for previous exams that sometimes these patients already have, and they just don't remember, or the lesions are not reported. So by the way, I think you have the talk now. Just one last question. Do you always biopsy or only after a specific size or condition?
Also, this is a good question. I would say that we mostly go for biopsy when we think that that will possibly change the management. Yeah. For example, if we have some localized with no distant lesion, which measures more than 2 centimeters, and for these patients, clearly there is an indication for surgery. And for this patient, for example, we are not going to make a biopsy if all the other checkup and workup is typical.
Mm-hmm.
Philip, I think
Merci, yes.
we are heading.
Congratulations.
Now I am your secretary, please.
Thank you.
Okay.
I am not able to explain what happened. Anyway, thank you so much. If I can get the next one, just to show my disclosures. Please, Mr. Secretary.
Yeah.
And the next one. So, watch and wait or active surveillance. It's a strange concept. We are not used to that. We have been educated as doctors, and we are trained to treat patients once we have performed a diagnosis. And we are really educated to cure our patients. And the problem is to know if we really feel active when we just follow up a patient. Next, please. As Felipe said, I think it's very important to take into consideration the patient opinion and feeling. And it's not the scope this evening, but we also follow up and watch and wait patients with liver metastasis of neuroendocrine tumors. And we face the patient, although your liver is full of tumors, I will propose follow-up active surveillance. Next slide. What does the patient answer? The patient answers, you are a murderer. I want a treatment for those tumors. Next one. What about this small net in your pancreas is nothing. I do propose active surveillance. And the answer of the patient is, most of the time, thanks, doctor. I was scared about surgery. See you in 6 months. So the patient is really important in the decision-making process. Let's come to the epidemiology of these tumors, because we are more and more faced to that problem. On the left part of the slide, you can see that more and more pancreatic neuroendocrine tumors are found at a localized stage, small tumors, the blue curve, and obviously with
the progress in imaging techniques, we are more and more faced with this problem. On the right part of the slide, according to a Japanese work, you can see that the incidence of small, less than 2 centimeter pancreatic neuroendocrine tumors has increased by 500% in the last 20 years. So it's huge. Next, please. You can see also the same in the very recent data from the SEERS database on the gray line, that due to improvement in screening, better detection, improved knowledge, we have now an incidence of small pancreatic neuroendocrine tumor that is close to 1 per 100,000 people. Next, please. Which people are prone to this type of tumors? This is very important. While the median age is close to 60 years of age, you see that non-functioning are a little bit found later than functional ones. And most importantly, that the incidence of these small pancreatic nets is high, or rather high, in older patients after 60 years of age and even after 70 or 80 years of age. Of course, those patients are not the best candidates for any surgical treatment. This should be taken into consideration. Next one, please. So what are we dealing with? We are dealing with the so-called pancreatic incidentalomas. What is that? A small, less than 2 centimeter pancreatic net. We will come back to this famous threshold of 2 centimeters. Non-functioning, this is extremely important. A patient with a small pancreatic gastrinoma, for instance, is by no means in this discussion. He should be operated on, of course, if no contraindication exists. The diagnosis should be certain. Certain has just been discussed by Felipe and Louis. What do we consider as certain diagnosis? I think that, of course, if EUS has been performed with FNA and you have a histopathology, the diagnosis is made. But in many cases, we can also consider a certain diagnosis with the combination of a typical CT. So this is a clear enhancement as shown in the clinical case, and a positive gallium PET whose sensitivity and specificity for the diagnosis is extremely high. So definitely, you do not get always a histological diagnosis, although, as Louis just pointed out, we like it more and more because I think we can be much more precise in the criteria for follow-up than just with a gross diagnosis on imaging. And the patient, of course, should not be symptomatic. Of course, all this should be adapted to age, and Felipe, I think you stated that, intrapancreatic location. It's clear that the risk of surgery is not the same for a pancreatic head tumor as opposed to the tail or even the body. Next slide, please. So just one comment on this famous 2 centimeter threshold. How was that determined? It was, I think, the consequence of several studies. Some of them are shown here. And ROC analysis has shown in most of those studies that the risk of death and the risk of progression was definitely higher, as you can see, both for progression-free survival, overall survival, for tumors that were between 0 and 2 centimeters as compared to those 2 to 4 centimeters with a hazard ratio of 2.74. This was, of course, found in several studies, and that came from all those studies. But it's true that less than 2 centimeters does not mean necessarily benign, does not mean that you will not get any lymph node metastasis. Next slide, please. Indeed, what is the frequency of those metastases, lymph node or even distant metastases, according to tumor size? You have here quite a number of series, and you can clearly see that around 10% of those patients do have lymph nodes, most of the case, metastases, much less frequently than in bigger tumors, but it is not fully negligible, around 8 to 10%. Next, please. And this is even more true if you consider G2 or G3 tumors, which are not so frequent, but G2 tumors might occur incidentally in the pancreas. And here, of course, the presence of lymph node metastasis is more frequent than in G1 tumors. Next slide. It was alluded to earlier. I think that size does not make all the story, and other parameters in this very interesting univariate and multivariate analysis performed 3 years ago show that other considerations should be taken. Tumor size, as you can see, was indeed significant both in univariate and multivariate analysis for prognosis. This is a series of 210 patients with small p-nets, which were followed for 3 years with 5-year recurrence-free survival of 94%. And what you can see is that much more important than tumor size appear biliary obstruction. I must confess that it is rare in pancreatic neuroendocrine tumors, but if present, of course, this is a very bad sign and should push to surgery. But more frequently, not rarely, we can see main pancreatic duct dilatation, and this has an odds ratio, which is not negligible at all, which reached 7.3 in multivariate analysis. So I think that dilatation of main pancreatic duct stands for aggressiveness of the tumor and should probably prompt the patient to the operating theater. Next one, please. EUSFNA is, as we said, interesting, but we should also remember, as we published 5 years ago, that the tumor grade might be underestimated by FNA. When we compare in this group of patients the results of pancreatic biopsy and surgical specimen in patients who are later operated on, and I must say that not all those patients had pancreatic incidentalomas. The work was done to compare the results of FNA and surgery. As far as G1 is was classically defined at that time as the Ki67 or MIM1 below 2%, biopsy underestimated the G2 grade. This is probably due to the fact that the tumor has different characteristics in different areas, and it's difficult to be sure that the tumor is G1 below 2 or 3% now at FNA. This is, of course, better if you put the threshold at 5%, you have less mistakes, but you still have mistakes. Next slide, please. So, what should we do when we have this type of lesion, for instance, here in the tail? Next slide, please. To be able to take this decision, we performed a follow-up study in 46 patients who had a diagnosis, p-nets, whose mean size was 13 millimeters. And we followed them for almost 3 years, as you can see. Few patients, 7 of them, had an increase in size. 8 patients were operated on, not always for size increase, by the way. And all patients had G1 non-metastatic, no lymph node metastasis in any of them. So quite reassuring results. Next slide, please. This was also the case in the Memorial Sloan Kettering Cancer Center experience, where they observed pancreatic incidentalomas below 3 centimeters in this study. And what they showed was that most of these tumors, as you can see on the left figure, did not increase that much. A few lesions as you can see in the upper part, did increase by 1 or sometimes 1.5 centimeter. As you can see in yellow, some patients were operated on, obviously not in majority those who had a size increase, maybe for physician decision or patient wish. But the right part of the slide shows that when you pair those patients, the patients who were just followed to those who got resection, in fact, you see no difference in overall survival or also in metastasis-free survival. So here again, reassuring data from follow-up cohorts. Next slide, please. Of course, we have to think about the complications of surgery, and even nowadays, surgical management is not always safe. And in the same study that I quoted earlier, mortality was 0 except for median pancreatectomy, where 1 patient died from surgery. Fistula, of course, is frequent, especially in parenchyma sparing surgeries, enucleation and median pancreatectomy. Hemorrhage is not frequent but possible. And functional disorders such as delayed gastric emptying is not rare after Whipple's procedure. So all this also should prompt to some care and prudence before deciding to send the patient to the surgeon. Next, please. However, in this audience, who is also, I think, made of people who are experienced in endoscopy, in EUS and interventional endoscopy, next slide, I think that we should also begin to think about other options than open surgery. I want, of course, here to mention endoscopic ultrasound guided RFA for these small pancreatic neuroendocrine tumors. This is one of the studies that was made. It's the French multicentric study. It included also pancreatic cystic lesions outside of the neuroendocrine tumors. Anyway, 12 patients had indeed small PNETs, 14 PNETs in 12 patients with a follow-up of 1 year. 12 out of 14 patients experienced complete cure after radiofrequency ablation, and in 3 of them, the disappearance of the lesion was delayed. They got 10% complications. 1 patient got acute pancreatitis, 1 perforation, and 1 duct stenosis. And Marc Barthé insisted on the fact that this was mainly in the initial part of their experience. Next one, please. So what can we conclude? What is recommended? As always, I like to refer to the INETS guidelines that probably will be refreshed soon, but the last one were published 5 years ago. Of course, and Louis, I think, insisted very nicely about that, a very, very careful diagnostic evaluation should be performed at start. Clinical presentation, which would be, once again, very reassuring, no symptom. Biology, not so important. Imaging, of course, paramount importance. CT or MRI, plus minus, in most cases, EUS. And I would say nowadays, if possible, in all cases, EUS-guided FNA and FNB. Somatostatin receptor imaging for sure. No more ocular scans, but gallium PET-CT. Some indications as discussed for FDG PET. The tumor is resectable but below 2 centimeters. Option 1 is follow-up for G1, low G2s, asymptomatic, mainly head tumors, no radiological signs suspicious for malignancy, and here we insist upon main pancreatic duct dilatation, and of course patient factors, including personal wishes, age, and comorbidities. Surgery should be probably proposed to G2 tumors, symptomatic tumors, and if patients absolutely does not, I would say, bear the idea to live with a pancreatic tumor. The other cases are not for us today. So thank you for your attention.
Thank you very much, Philippe, for your kind presentation. And thank you very much, Luis, Unfortunately, we don't have more time to continue with our discussion, but was a great pleasure to receive you here with us in our meeting. Louis, Felipe Coimbra, and Philippe, thank you very much.
Thank you very much. Thank you to all of you. And sorry for the technical problems, but I think we had the discussion earlier.
Yeah,
no
very
problem,
nice
no problem.
Yeah.
Thank you very much. We move on for the next activity. Marcos, bye bye.
Bye bye. Tchau, tchau.
Thank
Obrigado.
you very much.
Obrigado. Parabéns.
E em seguida a segunda palestra. Boa noite, professor Yamamoto.
Good evening, Professor Yamamoto. We are going to start this lesson, this mini conference on investigation of hemorrhage of mid-intestine. And we invited one of the highest authority, Professor Hironori Yamamoto. Professor Hironori Yamamoto was one of the ones to idealize double balloon. He's a professor and president of the Department of Medicine of Gastroenterology of Chihi Medical University from Japan. To moderate, we invited the two big experts of hemorrhage of the mid-intestine, Professor Adriana Van Safati and Kuga, Coordinator of Endoscopy of America Service. I yield the floor to Professor Yamamoto. Thank you very much, Professor, for your lecture.
Hello. Hi, can I start my presentation? Okay, let me share my slide. Okay, can you see my slide? Okay. Okay. Today I will talk about evaluation of small bowel bleeding. First of all, thank you for the invitation. I'm honored to present my talk here. And just a moment. Okay. When we see a patient with suspicion of small bowel bleeding, we shouldn't just insert an endoscope and look for a bleeding source in the small intestine. We should try to understand the pathophysiology, and we should list up differential diagnosis considering the patient's age, clinical history, physical and laboratory examination findings. What is the most likely diagnosis? We should choose it from disease categories considering the prevalence. Small intestinal bleeding lesions can be mainly categorized into the following three categories: ulcer, inflammatory lesions, vascular lesions, and tumors. This is the pattern of diagnostic approach. First of all, clinical information is important. We should collect information of patient history, underlying disease symptoms, physical and laboratory findings. Then we should consider underlying pathophysiology and make differential diagnosis. Therefore, knowledge and understanding of diseases are necessary. Bleeding site can be estimated by the type of stool. We should consider the color of the stool, but not only the color, but we should also consider characteristics, amount, and frequency of the stool as well. Typically, black stool indicate upper GI bleeding, and red stool indicates lower GI bleeding. However, color can change with the amount of bleeding and transit time as well. For example, massive bleeding from a duodenal ulcer can cause fresh red bloody stool if the transit time is short. We should consider the significance of the bleeding. Is this bleeding clinically significant? It depends on the amount of bleeding, and is the bleeding just one time, or repeating episodes, or continuous bleeding. We can estimate the disease type of the bleeding source from the bleeding pattern. Okay. Is it a repeating episode overt bleeding? That typically suggests arterial bleeding from vascular lesions, ulcer, or diverticular. Continuous mild bleeding from inflammatory diseases, and occult bleeding from tumors. And the age of the patients are also important information to estimate the type of lesions. This column is, the gray one is over 65 years, and blue one is younger patients. And there are significant differences between the elderly people and young people in vascular lesions. Vascular lesions are more common for elderly patients, and the diverticular is more common in younger patients. That's because of the macular diverticulum. And bleeding in elderly people, when you see bleeding in elderly people, vascular lesions are more common in elderly people compared to young people, especially people on medications such as NSAIDs, aspirin, antiplatelet agents. Underlying diseases should be considered, especially in elderly patients. They often have cardiac diseases, and taking low-dose aspirin and ischemic heart disease, and they sometimes have liver disease such as cirrhosis and angioectasia, portal hypertensive enteropathy, and varices can be associated. And the renal disease, the renal insufficiency can make the vascular disease and hemodialysis. This is a clinical practice guideline for enteroscopy published in Digestive Endoscopy. This is the Japanese Gastroenterological Association. And obscure gastrointestinal bleeding, the cause and the site of bleeding in the small bowel can be estimated by asking patients about the following points. That is, these are the clinical information that is very important. And this is the diagnostic algorithm for obscure GI bleeding. In Japan, we recommend, after the upper and lower endoscopy, we recommend plain and contrast enhanced CT from the chest to the pelvis. This is very useful. If there is an abnormal finding, then we can perform balloon-assisted endoscopy. And then treatment follows. If CT is negative, then capsule endoscopy can be performed. And if there is an significant findings, then we can perform balloon-assisted endoscopy or directly to the treatment. And if that is negative, then we should decide whether further workup is necessary or not. If yes, then even if capsule endoscopy findings are negative, we sometimes perform balloon-assisted endoscopy or Meckel's divertical, like this. This is an example of dynamic CT with contrast. Early phase, arterial phase is important. In this case, if the contrast, the image with contrast, this is also image with the contrast, but late phase, you can't see the tumor, but early phase, you can see the tumor very well. This is the gist. So after the CT, I performed the double balloon endoscopy and I found this small intestinal gist. And major cause of bleeding in the small intestine can be categorized into these 4 categories. And one is vascular lesions. There are several types of vascular lesions. So I made an endoscopic classification of small intestinal vascular lesions. Type 1 means capillary bleeding, oozing type of bleeding. Type 2 is an arterial bleeding. So the bigger one is B and the smaller one is A. And type 3 is arteriovenous malformation. And this is a very typical 2A, that is arterial bleeding, but small one. It's sometimes very difficult to find if the bleeding has already stopped. Can you see this fibrin here? Because of this fibrin clot, I thought this is a bleeding source and tried to clip it. Then it started bleeding. So this was the bleeding source. So once it stopped, then sometimes it's very, very difficult to find. And when you see a patient with active bleeding, I recommend you to perform double balloon endoscopy from the oral route. If you perform the double balloon endoscopy with oral route without preparation, then the blood is, you start to see the blood from the point of the bleeding. Because the small intestine has peristalsis, the blood goes down to the anal side. That means when you see the blood, the bleeding source is very close. So this is a melchmal. In this case, here is the bleeding point. And after you find the bleeding point, then I use observation under water, then stop bleeding like this. So small intestinal bleeding goes down from the bleeding point to the anal side. So if you perform retrograde insertion without preparation, then difficult to keep view and regurgitate the blood. And even with preparation, you regurgitate the blood and you miss the bleeding point. And if you perform antegrade insertion with the preparation, then you wash away the blood and easily miss the bleeding point. So I recommend you to perform antegrade insertion without preparation. Then when you see the blood, then make one clip, and then if the blood color turns to dark, then 2 clips, and we can find the bleeding point between these clips. And I published colonoscopy in flowing water for lower GI bleeding in the year 2000. That means underwater, you can see the bleeding point very clearly. But sometimes the bleeding, if the bleeding is relatively massive, then sometimes it's hard to keep a clear view with just water like this. So my colleague, Dr. Yano, started using gel instead of water, because in the gel, blood is not mixed with the gel. In the water, blood is easily mixed with the water. So this is the example. In the water, clear view can be, it's difficult to have a clear view, but in gel injection, then a little bit viscous, so the blood is not mixed with gel immediately. So it's easy to keep a good endoscopic view, and the bleeding point can be seen very clearly. And ulcer or erosions. This is a typical ulcer of the NSAID-induced ulcers. And this is Crohn's disease. These kind of ulcer lesions can be a cause of bleeding. And example of tumors. In addition to the gist, I showed cancers, including metastatic cancer, can be the bleeding source. And this is a lymphoma. Lymphoma sometimes bleed like this. Okay, and I want to present a case. This is a 26-year-old male who presented with recurrent passage of maroon to fresh blood per rectum for 1 year. Previous gastroscopy and colonoscopy does not show, showed only normal mucosa, and the patient was readmitted for anemia due to another episode of hematochezia, and repeat video gastroscopy and colonoscopy only showed duodenitis and normal chronic mucosa. 2 units of blood were transfused, and capsule endoscopy was performed on the same admission. And it showed some angioectasia, angiodysplasia in the proximal jejunum, like this. This is a case I was asked to perform double bowel endoscopy in a live demonstration course. So the plan they proposed was double bowel endoscopy and argon plasma coagulation. What do you think? But I performed retrograde double bowel endoscopy. Why? That's because the history doesn't match the findings they suggested. What is this? This is an ulcer. What kind of ulcer is this? Actually, this is a Meckel's diverticulum. So it was a Meckel's diverticulum, and I made tattoo, and then underwent surgical resection. So what was the problem? Clinical information is very important. Young man with recurrent passage of fresh blood, so and episodic blood, and required transfusion. That means arterial bleeding, intermittent arterial bleeding in a young patient without any underlying disease. So the most likely diagnosis was Meckel's diverticulum. So I performed retrograde double bowel endoscopy. Another case, 84-year-old female. She had distal gastrectomy and B1 reconstruction and advanced gastric cancer 1 year ago. And she had fatigue from the morning of the previous day and emergency transportation with syncope. And she had severe anemia. So that means bleeding, GI bleeding. So we took a CT scan, and this is the extravasation at upper jejunum. And we performed the double bowel endoscopy antegrade way, and there was bloody intestinal juice 50 centimeters from the gastroduodenal anastomosis, and marking clip was placed. Fresh blood clots were observed from 60 centimeters to 70 centimeters. The field of view could not be taken with water, and here, coming to the bleeding point soon. So a lot of bleeding And when excess gas was aspirated at the site of 60 centimeters, the balloon at the tip of the endoscope was half expanded, and then gel was injected. This is still water. It doesn't show. In the water, you can't see the bleeding point, but now gel is injected. With the gel, clear view can be, the view became clearer. And now you can see the bleeding point. So this gel immersion method is useful to secure endoscopic view even with massive bleeding. So I recommend to use a transparent hood at the tip of the endoscope together with the gel immersion, and then bleeding point can be identified and endoscopic treatment was possible. Like this. So this is a very good, good technique to find the bleeding point and perform endoscopic treatment. Okay. Conclusions. Deep enteroscopy, such as double balloon endoscopy, is available for accurate diagnosis and treatment for small bowel bleeding. And medical history is important to estimate the cause and site of bleeding in obscure GI bleeding. Clinical reasoning, understanding pathophysiology is important for correct diagnosis. Minimally invasive treatment can be selected by making a definitive diagnosis preoperatively. Gel immersion endoscopy is a useful method to identify the bleeding point. Thank you for your attention.
So, thank you very much, Dr. Yamamoto.
Hi, nice to meet you again.
Nice to see you. It's always a pleasure to see you.
Yes.
And we learn always a lot with your lectures. So thank you very much. And I'm here with Dr. Rogério Kuga. We both are going to ask you some questions.
Okay.
And very nice to hear from you that medical history is very important. I had one case and the patients had hematemesis. And then we know that the patient had the bleeding at the segment proximal of the trites angle.
Yes.
So I entered with the endoscope and to the third portion of the duodenum, and I saw a aortic fistula.
Oh.
So can you imagine if
that's scary.
Very scary. So the medical history is very important. So you have to understand. So thank you for this advice.
Yes.
So my question is, in the case you have a patient with massive bleeding.
Yes.
Do you choose for angiography or do you go with double balloon enteroscopy? After the CT scan is negative, do you perform double balloon? Or
it depends on the amount of bleeding. If that is really massive, and if it is difficult to keep the blood pressure high enough, then angiography is better. That kind of massive bleeding, the performing endoscopy is too risky. So pumping blood and then angiography and stop the bleeding. That's the best. But if you can keep a good vital, then the endoscopy, we choose endoscopy. Endoscopy is more accurate and precise diagnosis and stop the bleeding securely. So as long as endoscopy can be performed safely, then we choose endoscopy. But massive bleeding, angiography is better.
Okay, thank you.
Okay.
Uga? Doctor.
Hi, how are you? Dr.
Good.
Yamamoto, nice to see you again.
Yeah, nice
Adriana,
to see you.
Nice to see you again. See you healthy, Adriana and Yamamoto sensei. Nice lecture. Always a good opportunity to learn from you. And my thought about the enteroscopy in this lecture, I want to know about this viscoclear that you mentioned. That we don't have here in Brazil. What kind of substance is this?
This is drinkable. Dr. Yano started this procedure with OS1. OS1 is a gel for drinking, dehydration. For the dehydration, I don't know OS1 is available in Brazil or not, but that is a drinking material for dehydration. So it's okay to drink, and not that viscous, not too much viscous. You can aspirate the viscoclear easily through the accessory channel of the endoscope. So, it is a little bit viscous. So only a little bit difference can make a big difference when you use it in the bleeding situation. It is not mixed with the gel immediately.
Okay, even in upper GI bleeding, do you use this viscous too?
Yes. Okay. Very useful.
Okay.
Sometimes in the stomach and bleeding is the greater curvature side to some area where the bleeding point can be covered by blood or clot. It's very difficult to clear all the clot and find the bleeding point. But using the gel, you make a clear area under the clot, under the blood, and along the gastric wall, and inject the gel, and you can get a good endoscopic view and find the bleeding point. So it's very useful, even in the stomach.
Okay, thank you. Adriana?
Dr. Yamamoto, in the case that the GI bleeding, it's unknown origin. You don't know, you do the CT, you don't know where is the site of the bleeding. Do you start with oral route or anal route in Japan?
It depends on again, the clinical information we.
No, I know, but if you don't have the
any clue
about the bleeding.
Okay, then we start from the anal route.
Anal route.
Yes, if we want to examine the entire small intestine, we choose anal route first, and then we insert the scope as far as possible, and usually about 3 meters like that, and make markings with the clips, and then the next day we perform antegrade insertion to the mark. In that way, we make sure the entire small intestine is examined. The reason why we choose retrograde first is the retrograde insertion requires less sedation and has less complications. But the antegrade insertion sometimes require more sedation and could have aspiration pneumonia, pancreatitis. So we want to make the time for antegrade as short as possible. That's the reason.
So it's not, you usually don't perform both routes at the same day.
Oh, sometimes I do. Yes.
Sometimes
yes.
you do.
Yes, same day is okay. We didn't do it before. That's because we were using air for the insufflation. So if you insufflate a lot of air, then that interferes with the examination from the other route. But as long as you use CO2 insufflation, then it's okay to do the procedures on the same day.
The same day.
Yes, no problem.
Okay, thank you.
Thank you. Dr. Yamamoto, I want to know about the pediatric situation, about the double balloon enteroscopy in such patients. What kind of scope do you use? Do you use the P type or the T type? And you perform over, for example, 30 kilos, or do I have a range when you decide to perform or not in a pediatric patients?
Yes, we perform double balloon endoscopy for pediatric patients with general anesthesia. So the over 7 years old, we have no problem using a T type, therapeutic type. Most of the cases, we have to do some kind of therapeutic procedures. So the standard therapeutic endoscope we use even for pediatric patients. But for smaller patients, we use the pediatric type double balloon endoscope, P type, and using the pediatric type scope, the youngest age was 1 year old, I believe. Yeah, I have to check the exact year and month for the youngest patient we performed, but yeah, very young patient we sometimes perform. And so far, no complications. Because due to the size of the patient, we didn't have any complications.
Thank you.
So we use to do in children, in pediatrician Kuga, kids with 15 kilos. We can use the P type. I use Dr. Yamamoto in patients with Crohn's disease without the overtube. Well, I use just the push enteroscopy. And with 30 kilos, I use the overtube.
Good.
So, of course, with general anesthesia. Ne?
Yes, of course, we have to be careful. Careful, gentle examination.
Very gentle, very gentle.
Okay. I have a final question before we finish about that frustrated situation when we didn't find any source of bleeding after capsule endoscopy, deep enteroscopy, MRI, CT scan. What do you recommend for the patient in this situation? To wait another bleeding or to scan with another capsule endoscopy? What do you say for the doctor that asked this in this situation and for the patient?
I think for the diagnosis of the bleeding source, the timing is very important. If the bleeding stop, then some kind of lesions, such as the vascular lesion I presented, it's almost impossible to identify that lesion. So I recommend to wait for another episode of bleeding. And once the patient has another episode of bleeding, then perform examination immediately. That is very important. Timing is very important. Whether capsule endoscopy or double bolus endoscopy or enhanced CT scan, the timing is very important. As long as the patient is bleeding at the time of the examination, there is a high chance of finding the bleeding point.
Okay, thank you.
Dr. Yamamoto, in a patient with Rendu-Osler-Weber's syndrome with many angiectasias, what is your strategy for treatment? You go deeper and treat from deepest point, or you start doing when you are entering with the endoscope?
If my strategy is treating as much as possible, then I insert deep and then treat when I come back. But if there is a suspicious lesion, which is the bleeding source at that time, then I try to find that significant lesion, and as soon as I find the significant angiodysplasia, then treat it immediately.
I see. And the interval of the sessions with these patients with many angiectasias, 1 month, 3 months. It depends on the
yes, but usually in 3 months or so.
3 months.
And if the number of the lesions decrease, then prolong the interval.
Okay. Thank you very, very much. I know our time is over, so it was our pleasure to see your lecture and to learn once more with you. Thank you so much. Thank you very much.
You're welcome.
Very much.
Thank you very much.
Nice meeting you.
Nice to
Hope to see you again.
Yes, see you. Bye-bye.
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 Agora vem quem tá aí. Tá, mas doutor Yoshi tá aí?
Tá sim.
Doutor Luiz Carol?
Tá.
Lix, tá. Pode soltar o vídeo.
Nacional de Videoendoscopia Digestiva e Cirúrgica desde 1988. Trabalhamos com atendimento de qualidade na comercialização, distribuição e pós-venda de nossos produtos. Contamos com uma rede moderna e bem equipada de assistências técnicas espalhada por todo o Brasil. Além disso, somos a única empresa certificada para atuar no reparo e assistência de equipamentos Fujifilm. Labormed. Entre em contato conosco.
Boa noite a todos. Vamos dar seguimento aqui ao nosso seminário e continuando
do trato intestinal agora com GI tract. Eu gostaria de chamar o Dr. Gastroenterologia, Diagnóstico e Tratamento da Argentina, Director
para dar seguimento agora à nossa mesa, com a palavra Dr. Luiz Caro.
Argentina. Now is the floor, Dr. Luiz Caro. It's a great pleasure for me to participate in this prestigious event. Could you open the video?
Nessa mesa nós vamos ter
In this table we have,
além do Dr. Luiz como moderador,
after Dr. Luiz as a moderator, Lix,
Alfredo
Oliveira
da
Reis de
PUC de
Oliveira,
Campinas também,
from PUC
né,
Campinas,
brindando aí com sua presença.
Ok.
Pronto, Dr. Luiz, o senhor abre aí o seu vídeo.
you open your video, okay?
Está aberto.
It's open now.
Dr. Luiz aí abre o seu vídeo, eu vou então.
Aí está?
Okay.
Pronto, Dr. Luiz.
There it is. Dr. Luiz.
Com a palavra.
You have the floor. Good evening, everyone. It's a great pleasure for me to be invited by this prestigious team and to be tonight.
Estamos sem o áudio do Dr. Luiz. Enquanto a gente faz esse ajuste, Dr. Luiz, eu vou apresentar.
As we adjust your audio, I introduce Dr. Yoshi. Thank you, okay.
Pronto. Então, vamos ter uma apresentação de
We'll have a presentation of a case of treatment of colon neoplasia, diagnosis and therapeutics, and I am happy to introduce you Yoshi Takeuchi, PhD in Gastrointestinal Oncology from Osaka International Cancer Institute from Japan. Please, you can continue and start your presentation. You're welcome.
Can you hear me?
Just a moment. Sorry. Can you hear me?
Sim.
Sí, perfect.
Yes, yes.
Okay.
Perfect. Yes, sir.
Just a moment. I'm Yoshi Takeuchi from Osaka International Cancer Institute. First of all, I'd like to thank my for invite me to this great awesome conference. And now I'm trying to share my slides. Just a moment. And today I will show you one chronic polyps in the cecum. And I'd like to discuss with you the diagnosis and treatment strategy for the lesion. And during my presentation, I will ask you about the diagnosis and your strategy. So just a moment. Sorry. What about this? Can you see my slide? Okay. So fine?
Perfect.
Okay. So shall we start? The case was a female in her 70s, and she had no particular symptoms, and she underwent a surveillance colonoscopy at the previous hospital clinic. 20 mm sized polyp was detected in her cecum. And then she was referred to our hospital, our institute, for further investigation and treatment. She had NASH, non-alcoholic steatosis hepatitis, hyperlipidemia, and history of polypectomy. And her relatives did not have similar diseases, and she did not take any anticoagulants. Her blood test revealed mild liver dysfunction,
but no other particular abnormalities. Following slides will show you her endoscopic images. Here you can see a 20 mm size flat elevated lesion with mucus adherence on the correct contralateral side of the cecal Bowel valve. After mucus washing, a colonoscopy revealed a whitish superficial elevated lesion with somewhat indistinct borders. A reddish superficial elevated area with a prominent vasodilation could be recognized on the left side of the lesion. The total size was estimated as 20 mm. Next, let me show you indigo carmine chromoendoscopic images. On the right side of the lesion, the borders are somewhat indistinct and some mucus adherence is evident. On the left side of the lesion, the border is clearly recognized as a prominent area of redness with little mucus adherence. Here is a magnified and indigo carmine spleen imaging on the right side of white elevated area. This is whitish area, okay? A type 2 pit, namely star-like shaped pit, which indicates a hyperplastic polyp is seen, and dilated crypt opening is seen in the central area where mucus was adherent. Here is a close-up image of the reddish elevated area on the left side of the lesion. Dilated blood vessels could be seen in places, and structures that are assumed to be type 2 or 3L pit could be seen. Here, I'd like to ask your diagnosis and your strategy. So what is your diagnosis at this moment? Low-grade adenoma, high-grade adenoma, including intramucosal cancer, so-called high-grade dysplasia, invasive cancer, sessile-serrated region, SSL, SSL with dysplasia, or SSL with dysplasia, including high-grade dysplasia. So, Lix or Dr. Luis?
It's a great pleasure to have you here. It's a fantastic case. I think it's it looks like for me a sessile-serrated lesion, but you show little like pits, not only 2, but I think 3L, and maybe have dysplasia. I think SSL with dysplasia in my diagnosis.
Yes, I agree. I think it's a mix for the different tissue, and disappear a little vessel, and I think it has a dysplasia too. Yep.
I see. So probably you saw the whitish area is SSL, and a reddish area is dysplasia, right?
Yes.
Okay. Yep. Yes. Okay. Then, just a moment. Then next, what is your plan? You will observe with NBI more, or NBI with magnification, or use crystal violet. I'm sorry, probably you crystal violet is not so popular in outside of Japan, or you just go to endoscopic removal like cold smear pulpectomy or EMR or ESD without any more investigation.
I prefer before the resection
to use the MBI and with magnification too. I think is the route. What your opinion, Liz?
I think if you have, we always use it, but I think it don't will change my procedure, my conduct. I think maybe I conduct resect the lesion. If I don't have NBI with magnification, I think it's the same approach.
So what kind of removal method you use?
I think if I think in a dysplasia, in a sacerate lesion, I think I will, in my opinion, remove in block. And I think it's better to use EMR underwater. EMR.
Yep. Okay. Great. Thank you. So Professor Carlo thought you need more investigation because there is some dysplastic area, and Lix thought you don't need to do any more investigation because you will not change your treatment strategy. Okay. But for us, Japanese endoscopists, at least me, I was interested in the dysplastic area. So I did further examination with NBI magnifying endoscopy. Here you can see a magnified image of the right side of the lesion, whitish region, whitish area. And it was determined to be a JNET type 1 because we could not see the capillaries on the surface of the lesion. And as you can see, some clipped opening, it can be seen as black dots, suggesting dilated clipped opening, which is specific for SSL. And this slide shows a magnifying NBI endoscopic image of the anal side. This side. This area of the lesion. We can clearly recognize the boundary with the whitish flat area and reddish area. Unlike the right side, you can see a networking blood vessels on the surface of the lesion, and still there is no definite irregularity. The network looks almost homogeneous, similar shape and similar thickness of the vessels, and it was judged to be a type 2A in the JNET classification. But when we move to the distal side, I mean the oral side of the lesion, this is a magnifying NBI endoscopic image of the oral side of the reddish area. The surface structure was difficult to recognize in some areas. The vascular dilation, the distribution was somewhat uneven, and the caliber was variable in some areas, suggesting JNET classification type maybe 2B. Someone said 2A or 2B, the in between, I think. So again, let's discuss. What is your diagnosis?
Maybe I change a little now to SSA L with dysplasia, including T1S. I always use magnifying, but I thought if we don't have, we can treat this lesion. It's what I try to tell, but I always use it too.
I see. Okay. Sorry. I know you love magnifying endoscopy. I know. Professor Carlo, also,
Oh, yep.
you also think?
I think it's well, it's ASL with dysplasia 2, but in one picture, I has suspicion in 12 position o'clock. I think it's disappears some basal in this area. Sorry, I haven't the laser point, but in 12 of this lesion, I have a doubt. In 12 o'clock in the lesion.
12 o'clock?
Yes. That.
Around here? Okay.
Maybe for this area.
I see. So do you think this is invasive cancer or still
No,
intra?
I think it's
intramucosal.
Yes, intramucosal. Yep.
Intramucosal.
Yeah.
I see. Okay. So then I did crystal violet chroma endoscopy. This is a crystal violet stained image of the lesion's left side. I mean the whitish area. The lesion was diagnosed as you can see a star-like shape. Sorry, just a moment. Here, star-like shape. Crypt opening, and it's a little bit larger than the others. So we can say this is type 2 pit pattern, or some of the pit is larger than normal pit type 2, and so type 2 open pit. And next, here is the crystal violet image of the left side, reddish area of the anal side, proximal side of the lesion. Here, you can see a type 2 pit pattern.
Yep.
Here, and here is some opened larger pit here. And when I observed to the oral side of the lesion, reddish area, we could see some irregular pits. Here is large pit, and here is small pit observed. And it was judged as to be a 5-eye irregular pit. So it is totally different from the other part. So this will be the final question. So in summary, we could find a whitish area on the right side and a reddish area with a regular networking shape on the left side or anal side, and the irregular shape of the red area of the at the oral side of the lesion.
Yep.
So again, same question. Probably you will not change your decision, but again, what is your diagnosis?
Maybe it's the last choice, the last ASL with dysplasia with antis too.
Okay.
I agree.
Yeah. And what is your treatment strategy for this lesion? Leave it inside you? Probably no choice.
No.
Or cold snare pulpectomy, or EMR, including underwater EMR or ESD. The size is 20 mm.
Well, depend the costume of the work in this situation, for me, is EMR, including underwater MBR. I prefer to elevate with a solution and indigo carmine. But it's my custom in the work, you know.
I see. Okay. Yeah.
I prefer underwater EMR because I think the lesion gets small, and when you don't inject in the lesion, and then you have more R0 resections than conventional EMR for this type of lesions.
The question is, Professor Takeuchi Sensei, the question is...
call me Yoji.
Yoji,
yes.
Yoji. Do you use adrenaline in this case? No, for to damage of the bleeding. If when you put adrenaline, the border, the limit of the lesion appear more clear. What do your opinion about that?
I see. Basically, as Rix told us, underwater EMR is superior than conventional EMR. It's injection and lift, and so I prefer to do underwater EMR for this for such lesion, and for my underwater EMR, I never inject anything, so I never use indigo carmine. So indigo carmine or epinephrine for injection liquid. And when we observe the lesion with NBI, the border can be clearly seen. So I think we don't need to inject anything if we can use NBI or NBI magnification.
Did you mark the lesion before?
Good questions.
Pardon, sorry?
Did you mark the lesion
before? Basically no. But if it is very difficult to recognize the border, occasionally I make marking before the procedure.
Thank you.
Like with ESD or more?
For colonic ESD, we seldom make marking dots before the procedure. But in case of a very difficult case, in case of very difficult to recognize the border, then we put marking with NBI magnification, and then change to the therapeutic endoscope and do ESD.
Thank you, Yoji.
You're welcome. So can I show you my treatment for this lesion?
Yes.
So our final endoscopic diagnosis was almost same as you. Type 02A superficial elevated type polyp. The size was 20 mm as estimated. And the NBI showed type 1 white in the white part, and type 2 or maybe type 2B in the reddish part. And pit pattern was type 2 or type 2 open in a whitish part. It is suggesting SSL. And type 3L to 5I mild pit pattern, it is suggesting dysplasia or intramucosal carcinoma. Maybe you say high-grade dysplasia. So we consider this lesion is sessile-related lesion with dysplasia or adenocarcinoma. But there is no characteristic of suggesting invasive cancer. So we consider that it's a good indication for endoscopic removal. And we performed underwater EMR for this region. I'm sorry, I did not record the procedure on movie, but the procedure was perfect. After we can see normal type 1 pit around at the margin of the resected area. So we could confirm that there is no residue left after underwater EMR. And after the removal, the mucosal defect was closed with endoclips and procedure is completed. Sorry. Let me show you a pathological diagnosis in the following slides. These are resected specimen and mapped the distribution of pathological diagnosis. Also, the picture of the resected specimen should be usually taken with the oral side on the right side in Japanese rule. The picture is resected specimen. Picture of this resected specimen is rotated 180 degrees to compare with endoscopic images. Yellow lines are sessile serrated region, and the blue lines are indicating sessile serrated region with dysplasia. Here, dysplasia, and red line is indicating serrated region with adenocarcinoma. Let me show you the comparison between endoscopic image and resected specimen. The specimen was cut into 7 parts and evaluated in this way. And here you can see an endoscopic image. After careful comparison, it is likely that the sections were created in this way on the endoscopic image. And let me show you the section number 3. Here is the border of whitish area and reddish area on the proximal side of the endoscopic image. And section number 3 is thought to have been excited as shown in this line. The left side, a reddish part, was diagnosed as JNET type 2A with magnifying NBI and type 2 with pit pattern diagnosis. On the contrary, the right side was JNET type 1 and open type 2 pit pattern on crystal bulge staining. And I will show you the pathological diagnosis of this part. Here is in the reddish part, the cellular TPR was observed at the base of the gland, and it was considered to be a SSLD, a SSL with dysplasia. On the surface of the region, serrated structures were observed, which maybe have been recognized as an equal size type 2 pit. On the contrary, the right side, in the whitish part, you can see serrated, dilated gland, and it was considered SSL without dysplasia. And let me show you the endoscopic image and pathological findings of section 4, the oral side of the region. You remember this area, reddish area, showed a very irregular shape of the vessels and surface. You cannot observe the surface structure. And section number 4 is thought to have been excited as shown in this line. It was diagnosed JNET type 2B on magnifying NBI and type 5I mild irregularity in pit pattern diagnosis. And this is the pathological result of this area. atypical glands, atypical glands with cellular atypia were densely present, suggesting a well-differentiated adenocarcinoma in Japanese classification. Maybe it is named high-grade dysplasia in Western countries, and but the adenocarcinoma is limited in the mucosal layer. So anyway, but irregular shape neoplastic gland is densely arranged in this area. So the right side slide shows the distribution of pathological diagnosis on the endoscopic image, which is copied the distribution of pathological diagnosis on the resected specimen and pasted them on the endoscopic image. Whitish area was correspond to SSL, and reddish but regular area is corresponding to SSLD dysplasia, and reddish area was intramucosal cancer, well differentiated adenocarcinoma. So the final diagnosis was SSL with dysplasia involving intramucosal adenocarcinoma in Japanese criteria, which is suggesting the adenocarcinoma arising from SSL. Congratulations for your answer, and thank you for your kind attention.
Well, it was a very nice and beautiful case.
Thank you.
It's really, and thank you for your present, Yoshi. Lix, do you? I think we talked too much about this case.
Sorry.
No. Our talk about that case, the answer and questions. Do you have some opinion or talk about that? The procedure, the diagnosis, I think was a lot, but the therapeutic. Do you can to talk about the underwater, no water injection in this part of the world, or no injection? What do you prefer in this case? Leaks?
I think first of all, perfect diagnosis, good treatment, and fantastic documentation. I look for this. I try to do the same, but it's very, very difficult to do the documentation like you do in Japan. We always learn with you. Thank you so much. And I want to know if you use, first question, if you use acetic acid for success-rate lesions. I think it's very nice to see the limits and very nice to see the pitch pattern. I use it. First, I use JNet classification, and then I put acetic acid to see the pits. I think it's very nice for me, but I don't know if you use it. And the second, if this lesion, the same lesion, you don't have a suspicion of dysplasia, how do you treat it?
I see. Sorry, what was the first question?
What do you think about acetic acid in success-rate lesions?
Acetic acid. Yeah. It's very nice question. Good point. These days, acetic acid is very useful to diagnose SSL. So it may be effective for this case. But once we spray acetic acid, then we can't use crystal violet anymore. Of course, we can use NBI, but crystal violet staining cannot be cannot work well. So still I'm not sure about the efficacy of acetic acid to diagnose the dysplasia. It's occasionally, we use acetic acid occasionally, but basically, so far, I don't change our strategy.
Okay.
And next question was, if there is no dysplastic area of this lesion, yeah, I will talk about it on the later presentation, but cold-snare pulpectomy can be a good option for this such the SSL. But basically, I prefer to remove the lesion en bloc. Piecemeal resection is not so smart, so I will do underwater EMO. But it's just my opinion.
Okay, this is the questions I to do about that. What your opinion about the cold snare?
Yeah,
I think it's a very good case. If not, has a dysplasia or in our 12 o'clock teeth. Yeah.
Yes.
Thank you very much, Yoshi.
Thank you.
It's very rare to see sacerate lesions with invasive cancer. It's very rare in Brazil. We see a lot of sacerate lesions, but very rare to see with invasive cancer. And do you think ESG have any space in sacerate lesions?
For very large lesion, it is a bit difficult to diagnose dysplastic lesion in such large lesions. So ESD, unblocked resection, can provide more accurate diagnosis. So for very large lesion, it may be there is a space, there's a room for ESD. But basically, for SSL without dysplasia can be treated as piecemeal fashion. So cold-snaring or EMO is preferable, I think.
Yoshi, a questions.
Yep.
I know underwater we have a magnification, natural magnification in the border. What your opinion about the finish your worker with APC in the border?
Some reports, some studies report the efficacy of APC actually, but usually, even if we don't have NBI or magnification, it is easy to detect residue, polyp residue. So I don't do APC routinely after a piecemeal resection, but some reports is saying that it is very effective. So maybe in the future, maybe I will do. Maybe I don't know, but sorry.
It's okay. I understand that answer.
I think now it's time to do your second presentation.
Yeah.
Okay.
Thank you very much. The time is over. Thank you.
Okay, then can I show you my last presentation? Sorry. Can you see my presentation? Okay.
Yes.
So thank you for your discussion. And here I'd like to share with you some updates of endoscopic management of colorectal lesion with a discussion about treatment decisions made in the case just described. Here you can see my COI. As I showed you, the case was 20 mm size whitish flat lesion covered with normal white light image, which is located in the cecum. And here you can see a typical macroscopic features of SSL. SSL exists in proximal column mainly and looks flat and transparent or covered with a mucus cap. A WASP classification is a simple and well-known classification system for optical diagnosis of adenomas. Hyperplastic polyp and SSLs first, they classify the lesion to type 1 and type 2 based on the color, surface pattern, and vessel pattern. This is almost same as NICE classification. Then they use their 4 features of different four features to differentiate SSLs. Those are clouded surface, indistinct borders, irregular shape, and dark spots inside polyps. And when 2 of these features are positive, the lesion is diagnosed as SSL. And in our retrospective study, we investigated the endoscopic findings of SSL using magnifying NBI, expanded crypt opening. It's similar to black dots in WASP classification, and thick and branched vessels are thought to be a suggestive NBI magnification findings for SSL. Dr. Yamano, he is a kind of legend of SSL, reported open type 2 pit pattern, namely type 2O pattern with chromoendoscopy, which is specific findings for SSLs, and it corresponds to the dilated crypt in SSLs histopathologically. Type 2O pattern shows a similar shape with type 2, but larger than usual type 2 pit pattern. It is also corresponding to black dots or expanded crypt opening in NBI images. So we saw the right side or white part of this region must be SSL, and left side is showing more irregular pathology, suggesting dysplasia or more severe pathology. And next, let me talk about treatment options for this case. I think there are 3 major treatment options for such lesion suspected of dysplasia or adenocarcinoma, namely cold snare pulpectomy, EML, including underwater EML, and ESD. Let me start with talking about cold snare pulpectomy. In the last several years, we had a big paradigm shift with cold pulpectomy. Someone says it's a cold revolution. The biggest advantage of cold snaring is its safety. We conducted a multi-center RCT comparing hot snaring and heparin bridging, that is a traditional management of oral anticoagulants, and cold snaring and continuous oral anticoagulants, that is a new strategy, in patients taking oral anticoagulants, including warfarin and drugs. The results showed 12% of delayed bleeding in hot snaring with heparin bridging and 4% in cold snaring with continuous oral anticoagulants. We can say that cold snaring is so safe even if the patient's taking anticoagulants continuously. And Professor Michael Bach and his team reported the safety of and efficacy of piecemeal cold snare pulpectomy for large sessile-related lesions in retrospective comparison with conventional EML. It seems that CSP cold snaring is safer than conventional EML and effective as same as EML. So piecemeal cold snaring can be effective for a large SSL, and I agree with that. But still, we need to be skeptical for the vertical margin of cold snare specimen, the depth of cold incision. This is also a landmark report from Sydney. They noticed that we can have a white protrusion named CSDP in 14% after cold snaring, and 80% of CSDP contains pathologically muscularis mucosa. So that means cold snaring may not remove all of the mucosal layers. So we can say that the cutting plane of cold snaring is superficial, and the cold snaring may not remove all of the mucosal layers, while conventional EML can remove the deep submucosal layers. So the indication of cold snaring should be cautiously determined. It means that we need to keep in our mind that EML and the cold snaring is totally different procedure. Of course, the most correct polyp is limited to intramucosal. However, a high-grade dysplasia can occasionally harbor intramucosal invasion. So if we remove high-grade dysplasia with co-snaring, we can have residual dysplastic tissue in the wound after co-snaring. And I thought co-snaring is not suitable for the current case because I suspected high-grade dysplasia in this region. And next, let me talk about the ESD. Here, I'd like to show you the largest scale involving 2,000 cases, our Japanese multi-center prospective cohort study on corrector ESD. In the study, we experienced 2.2% of delayed bleeding and 0.6% of delayed perforation. Therefore, ESD is not so dangerous procedure for Japanese endoscopists anymore, but coagulation syndrome often seen after ESD. Even after complete ESD without perforation, patients complained severe abdominal pain without perforation but swollen cecal wall in the CT. We call this situation post-ESD coagulation syndrome, PECS. We conducted a multi-central RCT to investigate the efficacy of periprocedural antibiotics for prevention of PECS, that is PPAP trial. We enrolled more than 400 corrector ESD cases in this RCT, and the results showed that PECS occurred in 4.7% among patients received antibiotics and 7.5% among patients without antibiotics. It appears that antibiotics reduced the incidence of PECS, but the difference was not significant. So we concluded that routine use of antibiotics for corrector ESD does not decrease the PECS, and we don't have a good solution for prevention of PECS. So ESD may be a good option for this region, but suspicious for, but in our current case, there was no findings suggesting invasive cancer, and ESD is thought to be too invasive. And finally, let me talk about EMR and including underwater EMR. We conducted a multi-center RCT to compare conventional EMR and underwater EMR for lesions size 10 to 20 mm. And the results showed R0 reduction in underwater EMR group was significantly higher than that in the conventional EMR group. Also, unblocked resection rate was significantly better with underwater EMR. So we can say that underwater EMR is a very good treatment strategy for removal of 10 to 20 mm size corrector polyp. And regarding co-snaring, the depth of cutting plane was a big issue. But in a post hoc analysis of this RCT, we compared the resection depth of underwater and EMR and conventional EMR, and the depth was almost similar between these procedures. So underwater EMR can be a good treatment strategy for our case. So I have adapted underwater EMR for this region. Of course, the answer is not only one. We should consider many factors, but at least I can say that underwater EMR was effective in our case. So thank you for your kind attention. Thank you so much, and Merry Christmas.
Yoshi, thank you so much for your great presentation. I think you didn't tell us about your recent paper. It's very, very interesting, the codes there, because we always ask if I have a perforation with a lot of water in the column, and you gave us a solution. And you close the snare underwater, and then you aspirate all the water, and then you cut it. Fantastic, fantastic. Thank you so much. Thank you so much. I'm always learning. I hope to continue learning with you next year in WO 2012. Yes.
22. Yeah.
2023. Yeah.
Thank you.
Thank you very much, Yoshi. And you live in very, very nice city, Osaka. Very, very nice.
Obrigado. Obrigado.
Okay, we have to close the session. Thank you so much.
Thank you.
Rodrigo. Rodrigo.
Vídeo institucional.
Paulo Corrêa está em linha. Ele está.
Estou aqui, Rodrigo.
Bom, boa noite a todos. Estamos aqui na reta
Good
final.
evening, you all. Here we are in the last sprint of our international seminar on endoscopy and gastroenterology at Itaigara Memorial now. In order to continue, we'll have now a mini conference called large, non-pediculated large colorectal polyp. Mucosectomy, cold mucosectomy, or ESD. We will invite Dr. Michael Burke, who is a professor at Sydney University and also director of Gastrointestinal Endoscopy of the Westmead Hospital in Australia. Unfortunately, he will not be able to be here live, and so he has recorded a video, so let's watch his video. And after the video, I will be inviting Dr. Rodrigo Filippi, scientific coordinator of the Itaigara Memorial, and Dr. Paulo Corrêa, surgeon and colonoscopist with Syro-Lebanese Hospital, a full professor at SOBET, in order to discuss the presentation by Dr. Burke. So let's start with the recording.
So thank you for the opportunity to address this important meeting about this very important topic, ESD versus EMR. Can we meet halfway? Really, you could think about it as lesion-specific endoscopic treatment for large, non-pedunculated colorectal polyps. These are my disclosures. I'm going to talk about the general background, some lesion-specific considerations, the performance characteristics of EMR and ESD, and then a rectum-specific resection algorithm. The best evidence we can use to guide us in these decisions comes from these two excellent guidelines, the European guideline from 2017 and the more recent American guideline from 2020. They're very similar in content and approach to how to resect these lesions. And in 2021, when we consider endoscopic resection of colorectal lesions, we need to adhere to this concept of the lesion-specific treatment algorithm. This is taken from the European guideline. And funnily enough, the thing that's missing from both guidelines is the primacy or importance of lesion location considerations, right versus left colon versus the rectum-specific algorithm. So when we look at a lesion in the colon and we decide that we should resect it, we need to decide, is it adenomatous or serrated? Is it benign, or does it have overt or possible covert submucosal invasive cancer? And then we also make some reflection on the size of lesions. Lesions less than 10 millimeter rarely contain cancer and can be removed by mostly cold snare excision. And then, as I mentioned, location becomes important. So our goals for endoscopic resection of lesions of the gastrointestinal tract are to safely, precisely, efficiently, and completely resect the target tissue for cure, minimize invasiveness and avoid patient injury, avoid recurrence, avoid unnecessary expense, time expenditure, opportunity cost, and avoid surgery and its associated morbidity. We need, in summary, we need to make the best evidence-based medical therapeutic decision for the patient and the healthcare system, not the doctor and the ego. So we commence with overview assessment and then focal interrogation, and we're looking for overall homogeneity of a lesion. Homogeneous lesions, if they're flat, they don't contain cancer. You should be able to look at the lesion. If you're interested in a psychedelic pattern for your living room, use that pattern as your wallpaper. If you see a disruption to the pattern, then you know something else is going on. So here we see a nice type 3 pit pattern, and then we can follow it in. There's a demarcated zone. This is what we term loss of homogeneity, and here we see no pit or microvascular pattern and a disrupted microvascular pattern. So there are amorphous white areas, but also dilated tortuous vessels. So this is actually deeply invasive cancer. These 3 large lesions were referred to our center for endoscopic resection, but you see even in overview, you can see some disruption to the homogeneity. And if we look with NBI, we see this demarcation zone. So these are all examples of early cancer, advanced cancer, and they shouldn't be treated by piecemeal resection. And indeed, if there's suggestion of deep submucosal invasion like this, then really it requires surgery. The other consideration in the right colon is always to make sure you don't get caught out looking at what you believe to be a simple adenoma, which is actually surrounded by pale tissue. And in fact, this is a serrated adenoma with a dysplastic focus. These are rapidly progressive lesions which will turn to cancer in the interval between follow-up colonoscopy. So if you just resect this and leave the serrated tissue behind, you'll be dealing with an interval cancer when you next come back in 3 to 5 years. So in 2020 and in 2021, most small flat lesions need to be removed by piecemeal cold snare excision. This is very safe. It mitigates all risks related to bleeding and to perforation, pretty much all risks. It also will have a role in larger flat lesions, but high quality randomized controlled trials are required. And in bulky lesions, it's not going to have a role, at least at the present time. Bulky lesions need to be removed by electrosurgical techniques, endoscopic techniques, for example, here EMR. And we know that if you're in the right colon, then these defects need to be clipped up to prevent post-EMR bleeding, reducing the risk from 9 to 3% in the randomized trials, of which there are 4. We can also do this, this technique that we've described, which is controlled, intentional, full thickness on block EMR excision of early cancers that are less than 20 millimeters. So you see here, definite early cancer in a frail elderly patient. So we make an injection, we have a nice margin, we can deliberately take the full thickness and we see the target sign, line of mucosal incision of the mucosa and cautery line of incision of the muscularis propria. Later on, this would be a hole. This is a specimen target, so we just clip it up, very controlled. You can get a fantastic specimen and have some estimation of whether the patient's been cured. So for non-pedunculated polyps, flat polyps, 10 to 19 millimeter, the guidelines recommend EMR, but increasingly we're going to be looking at cold snare excision for flat lesions. You can do this, it's extremely safe, but there's a learning curve, and because there's often bleeding, we need to use dilute adrenaline in the injectate to minimize oozing, which is an independent risk factor for recurrence. And then we follow the plane very carefully, widely excised. We usually make the defect about 1.5 times the size of the lesion. It's actually not time consuming once you get the hang of it. Now we could do this in 5 to 10 minutes, previously 30 minutes, but recurrence is probably more frequent. We're halfway through a randomized controlled trial. Serrated lesions absolutely need to be removed by cold snare excision. It's a perfect match, low mucosal profile, thin lesion, soft tissue, piecemeal cold snare excision. Those with dysplasia, probably we need to go for EMR. You certainly want to take the dysplastic focus on block in a single large piece. Remember that serrated pathway cancers have a very subtle mucosal profile, but underneath they're often more advanced than the equivalent adenomatous or conventional pathway cancer. So these are the data that led us to realize that serrated lesions can be removed by piecemeal cold snare excision, mean size 30 millimeter, 2 large studies from Brisbane and our own group. and the results were very good. No recurrence, no adverse events. This is the comparison published in Gut last year of hot EMR historical group versus piecemeal cold snare excision. No bleeding, no perforation. Recurrence was more frequent. This is all the data. Recurrence at SC1 was 4 versus 4, and then at second surveillance at 18 months, 2 versus 1.2%. So it's very simple. Piecemeal excision, take half normal, half polyp, and work your way across, follow the plane, use the water jet to avert the defect edges, make the defect very firm so you can resect with a stiff thin wire snare, and you end up with a defect that's twice the size of the lesion, 1.5 to 2 times the size of the lesion. This is taken from the paper. You see recurrence, you see bleeding is negligible and recurrence very low in both groups. This is an example of a fully circumferential serrated lesion in the proximally ascending colon. And this is after piecemeal excision, no risk of bleeding. And then at 12-month follow-up, you see a well-formed circumferential scar, some suggestion of recurrence. In fact, the pit pattern's basically normal, so probably it's just an so we excise it for certainty. And you see here a Volscian technique against the end of the colonoscope, cold snare excision. We can make the area of excision wide and extensive, be certain we haven't left anything behind. This is an important point. Look at the firm upward, downward pressure using the up-down wheel with my left thumb. Push up very hard so you get a lot of pressure pushing down on the mucosa. The whole topic and technique of cold snare excision is a very important one, and it's beyond the full scope of this talk, so I could spend a couple of hours on that alone. So if we come to the performance characteristics of EMR, and these are all the various trials that were published over time. Here's our own Australian study, the ACE study. Can't find my pointer over here on the right. More than 5,000 lesions involved now. And so a couple of problems with EMR. We had bleeding, we had perforation. Bleeding is managed by clipping in the right colon, reduces bleeding from 9% to 3%. Left colon bleeding, the risk is only 2%. Perforation, we already worked out with the Sydney classification of deep mural injury published about 5 years ago. If you see these features, type 2, 3, or 4, you know you have to clip. So these are all target signs with some full thickness injury. Just have to recognize it. So when you see this type of white cautery ring of the muscle layer excision, a white cautery ring with inside a white cautery ring, you know that you have a target, you have to clip that up. And then what about recurrence? Well, this has been totally mitigated by the development of the technique of thermal ablation of the post-EMR margin. So that's now the standard of care, the original randomized trial published in Gastroenterology 2018. And if we look back historically, you see here down on the right bottom image, you see I held that up as an example 5-6 years ago, but you see even then there wasn't perfect ablation of the margin. Now in the open label multi-center experience, published in Gastro now in June or July this year, 1,000 patients, recurrence was only 1.3%. In my own practice, we never see it. So it's very, very effective at preventing recurrence. It should be done with snare tip soft coagulation. We have other data showing that APC is not as effective. That was an animal study published in Gut recently this year. So this is how it all looks. So 2A plus 1S or mixed nodular granular lesion. We take the nodule off en bloc, big piece, and then remove everything else by piecemeal EMR. Okay, sorry, I'll go back to the talk. There we go. So nodule in one piece, and then take the margins very wide, and that just work sequentially from the point of entry into the submucosal plane and work your way across. Aspirate gas, reduce the footprint of the lesion on the colonic wall, and so on. Water jet between excisions, and then at the end, snare tip. This is a good stepping stone to learning ESD. So, and that's how it should all look. Very aggressive snare tip. This patient will not suffer recurrence. You can use the same techniques at the anorectal junction. This is a series of more than 100 patients, also published in Gut, I think, earlier this year, last year. Negligible recurrence. You don't need to do ESD if you don't think there's any risk for cancer. And what about if there's scarring? Well, we just use the cast technique, cold avulsion followed by snare tip soft coagulation. Very, very effective. These are all previously attempted non-lifting lesions managed in that way. You may get some muscle injury, but you recognize that, clip it up. And you can see here, previously attempted non-lifting lesions, recurrences, very low. This is before the snare tip technique. And if we look at the data that incorporates snare tip, the data is even better. Recurrence is 0. So this is a large lesion, scarred. So the temptation is to do ESD, but it becomes very time consuming and technically challenging. There's no risk of cancer. It's a flat lesion. We can see that there's no risk of cancer. So we do EMR excision, start away from the scarred area, then work your way towards it. And now cold avulsion, and then snare tip soft coagulation. And then if we're worried about DMI, deep mural injury, which would be type 2, because we can't interrogate the submucosal plane, then we just clip up the center aspect. Easy to do, really easy to do. And then snare tip of the margin. This patient won't suffer recurrence. We have also huge data for treatment of recurrence. More than 2,000 lesions in this study, just about, it's already submitted, hopefully soon to be accepted. Recurrence after treatment of recurrence is less than 2%, especially in the era of snare tip soft coagulation, the post-EMR margin. I won't show that video. So what about rectal lesions? Well, ESD offers potential advantages over wide field EMR, potential cure of superficial submucosal invasive cancer, which can be overt or covert. We don't need to do ESD everywhere because it's not cost effective. And in fact, it's cost ineffective, and it also burns up endoscopy time. We showed this in this study published in Gut. If you were to do selective ESD, you need to do about 43 ESDs per 1,000 cases. Where you really need to consider doing it is in the rectum, where cancer is so much more common. And about half to a third of those are superficial and potentially cured by en-bloc excision. So the rectum's a completely different organ to the colon. Here's an example of overt cancer within a small nodule within a large granular lesion in the rectum. So we see this, it's at least high grade, possibly cancer. So we remove it by ESD. We do several of these each week, but we don't do it unnecessarily because we have so many EMRs to do, and we rarely find cancer elsewhere where we've done EMR. Here's another example, overt disruption to pit and microvascular pattern. So this is early cancer. So we do this by ESD. The rectum is more difficult than the stomach, and I think it's more difficult than the esophagus because there's so many blood vessels. ESD in the esophagus is very easy, and stomach is also pretty easy. But rectum, a lot of blood vessels, so you tend to get a lot of bleeding. You need to be very careful. Colon itself is probably easier. It also has a big advantage in those who are comorbid or stoma resistant. So here, obviously, relatively advanced cancer. So we can remove this by ESD, get local control of the disease. Patient can be considered for adjuvant radiotherapy. There's a little hole here we can fix up later. And, you know, maintain digestive continuity, avoid stoma. This is a patient who didn't want to have surgery, was recommended by MDT to have permanent stoma and proctectomy, declined. And so this was invading the muscle. So we did an intermuscular dissection, removed the tumor, and then he's had follow-up radiotherapy. You see here the circular layer, then we've taken that with the tumor and left the longitudinal layer. So this is the video. So you can see the tumors extending into the muscle there. So we very deliberately take the inner circular layer. You get the plane right, you get the traction right, and positioning of the lesion, patient fluid pool, then it's relatively easy, like so. So we have previously come up with this idea of risk stratification for covert invasive cancer. And basically it turns out that bulky lesions in the rectum and sigmoid have a high risk. So if you have non-granular or granular lesion with a large nodule, these have a high risk of containing cancer, even though you may not see it. So that's covert submucosal invasive cancer. It can be buried within the nodule. Flat lesions, when you split them flat versus bulky or nodular, mixed nodular, you see that sensitivity improves enormously to 91%. So in flat lesions, this has been published last year, or this year actually, in CGH, based on 1,500 patients. Yep. The risk of missing cancer is only 6 per 1,000 in a flat lesion. It's probably even better than that. In our practice, we virtually never miss it in a flat lesion. So when we see bulky lesions, then we consider, this is in the rectum and left colon, not the right colon where the risk is very low either way, but in the rectum, the risk is high, 15 to 18%. We have another paper coming that will show that very clearly. And so in these cases, we do ESD. Like so. This is the tale of 2 lesions in the one patient, same day. This granular lesion here we remove by EMR, takes 10-15 minutes, and this bulky lesion we remove by ESD, like so. Huge blood vessel. This is the problem in the rectum. So again, bulky lesions, again done by ESD. Very large lesions can be safely removed that way. And I was fortunate to write this review with my friends for Gastro on the role of ESD, and pretty much in the upper GI, I think most things need to be done by ESD, and in the rectum, a lot of things need to be done by ESD. But elsewhere in the colon, it's pretty much all EMR. So here an example, 18 centimeter lesion, mixed nodular, we absolutely do it by ESD, but it takes several hours. This is the specimen. The squamous margin broke off when we tried to remove it from the rectum, but you see here the anal canal and the 15 centimeters of distal rectum. For other mixed nodular lesions, if they're fully circumferential, another approach is that invented by Yamamoto, tunneling. This is very efficient also, and an easy technique if you're already doing POEM. So we can submit the specimen on a syringe to the pathologist. Definitely the patient gets a high-grade stricture. We have them on enemas. but everything goes back to normal eventually. This is a multiply recurrent distal rectal and anal canal lesion. And so we do this by ESD, like so, including some intermuscular dissection, and fully resect that lesion. Post-ESD stenosis managed by balloon dilatation initially, and then if it's sufficiently distal, then you can do digital self-dilatation, and that all works. So we've come up with this idea of a rectum-specific resection algorithm. This definitely optimizes oncological outcomes. This data was presented at DDW, and you can see here we had a lot of cancer in the universal EMR algorithm. When we use the rectum-specific, SMIC after EMR drops from 12% to 1%, and curative oncologic resection increases from 5.7% to 38.5%, because a lot of them are deep cancers, so they're not necessarily cured. This recurrence data precedes the snare tip. Now the recurrence is virtually absent. In fact, our ESD recurrences are more frequent than EMR. So in summary, flat lesions, you can definitely tell what's going on. High sensitivity for detection of cancer can reliably guide treatment decisions. EMR is the safest, most efficient, effective method to treat most lesions, except in the rectum. Recurrence should be infrequent in the era of EMR margin thermal ablation. Scarred, previously attempted lesions are easily treated by EMR or CAST or occasionally ESD. I think ESD is not really required. The rectum is definitely a different organ. Only flat lesions without overt SMIC should be treated by EMR. The remainder require ESD. And in the absence of optical evidence for deep submucosal invasion, complete endoscopic resection provides precise, definitive T-staging as the first step for most lesions, because all treatment options are still available to the patient. And finally, in the elderly comorbid stoma-resistant local advanced lesions, local disease control can be obtained by ESD, and then adjuvant therapies can be considered. So thank you so much for the opportunity to give this talk. I hope you've enjoyed it. Thank you.
Paulo, boa noite.
Paulo, good evening. Do you hear me well? Paulo Correa, is this you? Do you hear me well? Hello? Paulo, unfortunately, you have seen that actually there were no images on this presentation. Can you hear me well? I cannot hear you, Paulo. Not here in the room, not in the room. Not in the room. We're just listening. We're hearing you in the Zoom platform, but not, they're not. I have my microphone on. I can hear Paulo perfectly well. My audio is on, and I'm hearing you perfectly. This is also. I think you have a problem in the room, Rodrigo. That's right. My volume is at the top. It's maximum here. I cannot raise the volume anymore.
Pode falar agora, Paulo.
You can speak now, Paulo. Do you hear me well now? Can you hear me? Rodrigo, do you hear me? Do you hear me in the room, Rodrigo?
Pode falar em português, Paulo. Pode falar em português.
You may speak in Portuguese, Paulo. Yeah. Yeah, they're all speaking in Portuguese in the room. Yeah, I can hear you, I can see you, I see you're thin, you're lean, right? Your face actually is a thin face, I can see it. But Rodrigo is not listening, hearing me. I can hear you well now. Great, excellent. Unfortunately, we did not see the images by Dr. Bork. But Paulo, let me ask you a question now. Up to how many millimeters do you do polypectomies? I'm sorry, I did not hear you well. Well, cold polypectomy, what is the kind of strategies that you use for that? I would like to better understand your experience on that. Make a more continuous kind of point, especially because the presentation of Dr. Takeuchi will help us in the way we think that out. Okay. Actually, what we have seen out of the literature, our experience over the years as well, that we realize that in lesions of up to 3 millimeters, it makes no difference actually using well, cold snare or the pincers themselves. Sometimes when we remove this small lesion with this cold snare, we sometimes lose a fragment. Dr. Takeyoshi mentioned the cold revolution. And this is something that really bothers me a little, because there is a big Achilles heel in terms of the cold snare resections, because what happens is not exactly a polypectomy. Actually, it is a shaving. This is what we do. So if we look at the literature, we will see that in some studies show that up to 30% of that of those lesions, they do not have even the muscularis mucosa represented there. If we have, for example, high-grade lesions, we don't know if they are invading that area because we do not have a representation of that specimens, and that is a big Achilles heel in terms of cold snare polypectomy. So I think that studies have shown that the greatest advantage of that technique is for those lesions from 4 to 10 millimeters, and those patients who will undergo the maintenance of the anticoagulation system. Those are patients who cannot stop that, and literature shows that this happens because of that Achilles heel, because as the resection is superficial, it does not reach the deepest vessels of the submucosa, so the bleeding rate is lower. And today, we already have several studies go underway, and though lesions smaller than 1 centimeter, they still need to be resected with some kind of current. The greatest fear of that resection is exactly late bleeding and transmural adhesion, thermal transmural adhesion, which may happen also at a later stage. The way for us to bypass this, I know several colleagues also do the same, is to use only pure cutoff currents. The pure cutoff current will not damage, will not harm the colon wall, and it will promote a more elegant cut of the specimen. It will remove what we need, muscularis mucosa and submucosa, that we may remove in amounts that are similar to that of an ESD, depending on the size of the lesion, depending on the place and the site where the lesion is, and that brings a number of benefits. So it's important to assess if we really reach endoscopic healing or cure. But in general, I would say up to 3 millimeters makes no difference. Cold snare, or could be also a biopsy tweezers. We know that this lesion should be up to 3 millimeters. From 4 to 10, we might use cold snare, but it's important to remember that the cold snare today, we have dedicated snares that are colder and more tough, making an appropriate resection of the surgical piece. When we used the old-fashioned snares, that resection was not of good quality. But if we use a dedicated snare for that, and in the bigger ones, we would do a mucosectomy or something like that. You heard that Dr. Burke, he was very excited, even more than what he could even be. But personally, I believe he is right in this aspect, as mentioned in the Japanese school, in which they said that the endoscopic resection of the submucosa brings advantages to the patient, and I believe that we should continue in this way. We were very permissive over due to the learning interests on the part of the younger ones, and so procedures were carried out lasting days, up to 2 days, so that they could achieve the final or the end results. I think this is not justifiable. I think it is an exceptional kind of method. It should be well mentioned and indicated in medicine. I think these are the points I would like to make. And thank you very much for the invitation. I should have thanked before I started my comments. So now we're open for questions. Okay? Thank you. Exactly this, Paulo. Let's set a number, let's say 10 millimeters. We tend to do cold polypectomy here. We place it, we actually aspirate the mucosa to get a little bit more of image. We aspirate, we use tweezers, the specific snare, which allows, it's a specific one that actually allows a broader kind of extraction. It doesn't matter if it is a low or high grade lesion. That's one of the points I would like to discuss. And the second is, I agree with you. I rarely use coagulations, especially on the right colon. I use more often the cutting. I think you burn less and you have a study of a specimen that is a better kind of study. This is my opinion. I think that you maybe agree with that, right, Paulo? Then I would like to hear Victor's opinion as well. As when Eduardo looks at the low grade, he finds compromised margins. Oncologists will die. So I'd like to hear his opinion. But Paulo, please, that's you. Yes, I had the opportunity to start with EMR mucosectomy in the 1990s. I learned that procedure with Dr. German Way. In an international conference I attended, he showed some of the very first cases in which I had the opportunity to see a flat, there was a flat lesion in the right colon, so he did this mucosectomy. But I'm somewhat neurotic regarding lateral and deep margins. I leave at least 3 millimeters of side margins. The deeper, the more submucosa I remove, the happier I will be, of course. Sometimes it happens that we will cure the patient, but it's important to remove, but without puncturing. And Dr. Takiyoshi actually showed a minute ago that they give preference to the underwater technique. And we also have one of our assistants, a partner of mine, who is a very dear person, who is the person who uses the most this technique, and he has had very important results. And he also communicated those results among us. I do not do underwater. I like classical mucosectomy, and I have got adapted. I believe my results have been of very good quality, but I see the underwater as a very real option based on what Lix mentioned on the previous session, that this lesion that separates the muscularis, it is smaller in size, but we may be careful. For example, using the water which is injected, it showed that Takiyoshi was aspiring before cutting. As I do not use water, I don't do that. I simply resect the session. I try to recover it in the best format or shape. So the important thing is what I said. It's important that we work on the lesions in which there is some kind of, if there is a suspicion of malignity in terms of the lateral margins, we try to find the best solution. Good evening, Dr. Paulo, Dr. Rodrigo Felipe. I would like to thank all of the group and the committee, organizing committee of this event, which is now coming to an end, but with great presentations as well. And well, about the lesions with lateral compromised margins, I will focus on the lateral margins because the deep margin, I think it's very clear that compromised deep margins, they are a surgical indication. Based on that criterion, there's nothing else to be said. But the lateral margins, when they are compromised, we have to assess what is the type of dysplasia of these lesions or the degree of invasion of those margins. Margins with low-grade dysplasia, I think that's very clear that we may complement in procedures to be carried out at shorter periods of time. Maybe we may complement earlier or trying to not exceed these processes 3-6 months later. Then I look at the different characteristics, the features of the lesions and the strategies for the lesions depending on their size. So we realize in our daily life that lesions, in bigger lesions, we have some difficult time in terms of doing en bloc resection. So, for example, if we have some kind of difficulty in those lesions, we have to assess the surface so that we may predict the degree of invasion before we carry out the strategy. There are lesions we may use those strategies in fragmented lesions. And in fragmented lesions, we have to understand that there are these little islands in the segments where we will be fragmenting. So if we're going to make an avulsion technique using hot biopsy pincers, for example, even doing a complementation with argon plasma, they're all strategies for us to try to reduce recurrence. Trying to answer Dr. Felipe's question, vertical positive margins of the cure criteria, even they do not contain lesions, that would actually do a lymphadenectomy. In the case of lateral margin with low-grade dysplasia, or even in cases of high-grade dysplasia, I would complement with endoscopic resections. Let us hear the opinion of our oncologist. Good evening, you all. Congratulations, you all, for the excellent event. Look, Felipe, you know I admire and I'm an enthusiast of minimally invasive surgeries. I think today what an endoscopist does, the way I see it, for me, endoscopy is a minimally invasive surgery. So it is very clear throughout this seminar that the previous examination or analysis of the lesion, knowing that for lesions above 20 millimeters, knowing that the chances, the odds for dysplasia are significant, the use of chromoscopy being either virtually done or not, I think a good endoscopist with very good quality, that provides a whole armamentarium so that the oncologist or so that the physician may decide for the best strategy. Regarding the strategy itself, I'm not the most appropriate person to discuss. But from the perspective of the oncologist, I think that cancer has to be resected en bloc. If there is a suspicion, the lesion should be approached at least with an attempt of an en bloc resection so that the vertical margin, I agree with Victor, that is fundamental, but the lateral margin as well of the cancer component, that margin within as much as possible should be removed en bloc with negative margins, like Paulo mentioned very clearly. Maybe 2-3 millimeters would be the appropriate thing. Obviously, there are situations in which you do not have the appropriate technique, and unfortunately, we sometimes cannot do it in very big lesions. And a discussion I have with my endoscopists is about the lesions of the lower rectal area, because unlike the sigmoid and colon, in which if there is a vertical component of cancer, or even lateral one, in which you recommended laparoscopic surgery with low morbidity, low lesions or low rectal lesions that may indicate amputation. And so, well, I think these are situations, and if you have the alternative to conduct minimally invasive surgeries like transanal meetings, etc., they are alternatives that the endoscopist has to take into account, that when they find large plastic lesions, and if you have the possibility of doing an en bloc or resection, or if you're going to have a material, which here we may receive fragmented material. So the pathologist does not have a way to determine the negativity of the margins. This is a situation that should be prevented. And in our discussions that we have had here in Bahia, this has improved over the years. We have been improving pathologists, better analyzing our surgical specimens, and every time trying to resect. Just answering your question, I agree with Victor. Low-grade lesions, risk of recurrence is higher, but acceptable. But a high-grade dysplasia with this nomenclature today, in terms of superficial tumors or in situ tumors or invasive tumors, in these cases, it is important for you to do an appropriate resection to avoid or a surgery which might be unnecessary. Paulo, your comments? One of the things that I think is still to be complemented here has to do with bleeding and perforation. And Dr. Burke was very clear. He was very confident in saying that today we may come across those or overcome those adversities, or using endoscopy. There are some cases that should be treated prophylactically regarding the bleeding itself, but in general, what we have used are lesions in the proximal right colon, especially the ascending colon, both the proximal and cecum greater than 1 centimeter. We have treated that, trying to reduce, as he showed in his series, from 9 to 3% of bleeding. We have used that indication. Another indication that we use is when we observe an active bleeding, but when we see vessels that underwent amputation that might bleed, hematomas or bruises of the submucosal. I think these are the kinds of situations in which we have a prophylactic kind of clipping so that there's no future bleeding, but that does not guarantee anything. We had some cases, not ours, but we have had a report of some colleagues in which there was bleeding even by using the clips. And we become very at ease today in terms of possible damages to the wall of the colon using the clips. I think the clips have actually made the endoscopists work very much better, because that avoids or that prevents different types of situations. For several years, we do not recommend an immediate surgery in the cases of colon perforation. What is your experience today, Paulo, regarding the use of padlock for colon perforation? Actually, I have never used it. The youngest, those who are younger in the service, they have used it both in high and low grade. And we have done the repair of a rectovaginal fistula using padlock, and actually it went well. There was a closure of that fistula. The patient benefited significantly from that type of procedure. But what we know is that this is an accessory which is not that easy to work with, because it takes a little bit out. It takes out a little bit of your visibility. So we work with a gap. In this case, advanced cases, we lose a little bit of visibility, and its handling requires a little bit of training. Like what happened when we started using the clips. So this is a very interesting situation for some punctures that are circumferential and smaller than 5 millimeters. It could be good for that, but the major difficulty in terms of endoscopy to repair the lesions of the wall, the colon wall, is when they're starry kinds of lesions. But when they are linear, it's okay. But if they are starry, in which we cannot cause it to be totally closed, sometimes intersection between different lines of rupture may happen, and a leak may happen. But in the case of linear lesions, we have done very well. Any other question, Paulo? So I'd like to thank you for your presence. Thank you so much for your contributions. I hope to see you face to face, right? Well, going to Bahia is always a pleasure to me. Feel invited to that. Thank you very much, Paulo. Good night. Good night to you all. Let me invite Professor Lix and Professor Celso to wrap up this event. Are they still online? Yeah, here we are, Rodrigo. So I would like to thank my scientific committee, Marcos Loriani, Nelma, Eduardo, Victor, and I would like to thank especially Celso and Lix, who were very supportive for this seminar. They were We discussed many things and exchanged ideas, and I would like to thank our sponsors as well. So I'd like to finish this, but before finishing, I pass the floor over to Celso and then Lix. Thanking you all in advance, and we hope to have the 4th international seminar next year, right? Celso, the floor is yours, and then Lix. Perfect. Again, I would like to thank for the invitation from a great friend, Rodrigo Felipe, and working with Lix. Well, we're very much used to working with him. We have been doing this for some years now. And it was a great pleasure working with all you, all these guys, all this staff. I would like to congratulate also the organizers of this meeting, the GT5 staff who organized this perfectly. I had already had the opportunity to thank all those who took part in it. I think that the themes that were discussed here were very important and very updated as well. They really make us go back to the study and also to the deepening of knowledge, be them basic or advanced regarding diseases of the GI tract, and it also shows quite a lot in terms of management. This year, we have had the introduction of the bile and pancreatic pass, and Rodrigo will assign me this kind of discussion. I hope we have pleased those who have already watched, and let's get better for next year. It's important that we improve and move forward regarding the different presentations, right?
Tem que tocar nesse assunto, né, Celso? Tem que tocar nesse
All the palestra is referring to soccer team in São Paulo. Well, no way, I cannot forget that.
Vocês ficam no Mundial, a gente vai
Doesn't matter. While you stop at the World Championship, we fill in our shelves with many trophies. Well, okay, I would like to thank you all who have taken part of this training, those who have been here so far, and the guest lecturers. They have all been very, very good. I would like to thank the organizers as well, who made this meeting or this event possible. I'd like to thank the sponsors and let you know that this course, if there were any failures, I think that we're all humans. Sometimes, a little bit in the beginning, I believe that this was minimized by the excellence of the presentations, of the discussions, and with Michael Burke, Mauro Correia, and all others. I think we cannot forget to think about the 4th seminar, and you may count on us for that. And again, thank you all very much. And now, Merry Christmas to you all and a great New Year. Wish we'll all be together again. Good night to you all. Good night to you all. Merry Christmas to you all. Bye, Paulo. Good seasons to you all.